Okay, we'll go ahead and get started. Call the meeting to order. Thanks everyone for being here. And I believe you said, Liz, we have one, is that right? And who is on the line?
We have no one online. It was going to be Dr. Smith, but he will be unable to join us this morning, unfortunately, with the last minute conflict.
We have 6 members.
Yes, we have 6, and Dr. Bleacher should be here shortly, so we'll have 7.
Okay. So we have sufficient on.
Correct.
Okay. All right, as far as the chair's report, I'd like to recognize, since this is EMS week, I'd like to recognize our EMS colleagues, our 2 distinguished colleagues sitting here at the table. Yes. So, but all EMS, I'm sure you all speak for all EMS, even though you're here, but we appreciate you. We had some activities yesterday in Macon at our trauma center where we had Trauma Survivors Day, and EMS, firefighters, first responders, nurses, we all got together and had some great 2-patient stories. And some of the, we had a reunion of the EMS personnel and firefighters that took care of those patients in the ditch. And then the patients got to be reunited with their caregivers there. And that was a very touching moment. Actually, some of the providers thought the patient had died. They were so bad at the scene. So this was a great chance for sort of closure and to get together with a very happy outcome. So we appreciate everything EMS does. I will give a personal story there. You never know, and this was sort of the theme yesterday, you never know what's going to happen to that patient. And so you can't give up. And you have to do things at the scene sometimes that you think, I just don't know how this is going to end. Yesterday, you know, like this patient, they thought was not going to make, they actually thought the patient died and was going to die. And then they come to find out because of their efforts, the patient made full recovery. And so you just never know. On another note, a personal story I have that affected me. I had a good friend that several years ago, not in Macon, but in another EMS environment region, had a terrible car wreck and ended up being brain dead and obviously didn't make it. But because of the care the providers gave that day, really working hard, that patient, my friend, became an organ donor and affected multiple other lives because of what was done in the ditch that day. And that gave me personal closure and the family because we lost the battle with his life, but we knew that it wasn't in vain. And so thank you for what you all did. Sitting here at the table, but you never know what effect you're going to have out there. So my word is keep chugging and doing what you can, but you never know what the outcome is going to be. So thanks to EMS across the state and all the first responders for what you do. I know the last couple of meetings, you know, as I've looked at the packets and things, I've been amazed at the amount of volunteer work that goes on. You know, this packet is pretty thick with committee work, and without the committees, the commission would not be anything because this, the people sitting at this table, we can't do all the work that needs to be done. So thank you very much. Everyone that participates on a committee, if you're not on a committee, please raise your hand, send an email, we'll get you on a committee. We've noticed over the last several years, you know, there's been expansion, more people are volunteering, more people are being on committees and leadership roles, and we're very excited about that because there's just so much work to do. So thank you for all the volunteers and everyone that participates. Really have given us something to write about here, giving Liz something to put in this packet here. So And then finally, great news from our level 3 and level 4 trauma centers and our rural committee. You know, they work really hard. I don't want to call out any names, but we'll leave somebody out, but they work really hard on doing their cost analysis and cost survey like we did for the level 1s and level 2s, which gained national recognition and now is like the leading paper on what the true readiness costs for level 1 and level 2 trauma centers are in this country based on the ACS guidelines. There was no data for level 3s and level 4s. It had not been attempted. So they rolled up their sleeves. They worked on a survey. You know, they have limited resources in those 3s and 4s, but they pulled it off and the survey data came back. And so we sent that in as an abstract to the American Association for the Surgery of Trauma, where the level 1 and level 2 data was presented. And it was accepted for a podium presentation at the national meeting in September. And so that'll also be considered for publication in the Journal of Trauma. I'm super excited about that. That gives the level 3s and level 4s national prominence now, and get the word out sort of what some of their costs are. You know, some of the data is rudimentary, you know, it'll only get better, but this gained national attention because there's just not data out there to help our level 3s and level 4s. So this is the first chance to really get them on a national stage and say, hey, this is what our costs are, this is what we do, this is where we need help. So I'm really excited about that. We'll get more information to you about that as we develop the slides and the presentation. So I think at this point, I'll turn it over to Liz for starting the administrative report.
Sure. Thank you, Dr. Ashley. Good morning, everyone. And again, thank you and happy EMS week to our EMS colleagues, as Dr. Ashley said. And last week was actually Nurses Week and Hospital Week. May is a busy month and intervention month. We got a lot going on.
It was also Mental Health Month. Does that have
Any correlation?
I believe it does. Yeah, I believe it does.
I want to sign up for some of the webinars.
Good timing on their part. Just want to remind everybody that the packets for this meeting and all the information that Dr. Ashley mentioned, there's a lot of committee work going on, is always online before the meeting, published online, so you can access any of this. And we have attendees in webinar mode, but we want to still make this as interactive as possible. So put your questions in the chat. If something comes up, this is just a good time for us to kind of have dialogue around it. But the first order of business, I think we have to approve the March 2nd and the called April 28th meeting minutes, which are included in the packet. So among the commission members, if we can get a motion, or if anyone has any edits to any of those.
I'll make a motion. I read over those.
Second.
Okay, motion.
Okay, so it's open for discussion. Any questions, comments, concerns?
Looking at Courtney.
Well, Courtney is very studious.
Is
And
very-
so if it
very-
gets by the eye of Courtney, then the eyes are dotted and T's are
As long as
crossed.
don't put any big words in there.
That's right, that's right. Single syllable word.
So I count on Courtney to pick out anything that was missed. Okay, all those in favor, aye.
Aye.
Opposed? Okay. Good care.
All right, we'll move on. Just wanted to start off with a huge shout out to one of the members in our audience. I'm so sorry, Jesse, I have to just embarrass you. She's over there saying thank you. I can't see her. But last month, was it last month? Yeah, at the Society of Trauma Nurses annual TraumaCon, the annual meeting of our professional society for trauma nurses, Jesse was awarded the leadership award for STN. So lots of nominations for that. Again, that's a national award. Jesse, as you all know, is the chair of our Georgia Committee for Trauma Excellence, which is essentially comprised of all the trauma programmatic staff. So after this beautiful photo with the STN president who presented it, Jesse and I got to have some fun with the props at the photo booth. So we've got some photos that maybe weren't packet worthy, but anyway, it was fun. It was great. So great job, Jesse, representing Georgia as we've become known as leaders in many things nationally. It's really great. So
It really is phenomenal. So congratulations, Jesse. I mean, that to be nationally recognized and then to know you're leading here in our state. So thank you very much.
Lots of opportunities here,
Must be doing something right.
I guess.
And
or
her-
Somebody's paying the judges.
Her whole team, including her trauma medical director, flew out to support her accepting this award, which was pretty phenomenal. They flew out and then flew back.
That's right.
So it's pretty cool.
might have been some gambling. in the
Yeah,
casino.
Well, I wasn't gonna mention that.
Okay.
Yes, yeah.
Okay, moving on to the super speeder revenue. I include this in your packet always because now that the funds are dedicated to our trauma trust fund, Katie has developed a spreadsheet that we can track revenue, cumulative revenue. It's on page 20 in your packet if you're following along. It's the last table. And the reason it's so important to track this is because we've got to make sure that we are not in a budget shortfall because we're essentially eating what we kill, right? So, and you can see that there's been a little bit of an erosion of some of the original, we had a nice, we started off a little slow and then we kind of made up for that and then some. And then the last few months, there has been a little bit of a shortfall. And from some months, there can be a swing like Katie, as much as like $400,000 or $500,000. So that makes a huge impact on our bottom line. So we're still up by 2%. And these are the numbers that you're looking at here are through April. So we'll keep a really tight eye on that because again, that gets put now on the front end into our trauma trust funds. So unless there's any questions on that, we can move on.
Liz, do we have any idea on why that's the case? Obviously, people are speeding less, but do we have any idea why that's the case?
Yeah, good question. I don't know if they're speeding less or they're just not getting caught. Or getting fined,
And it's
so.
actually based on when they receive the payment
Mhm.
for the super speeder bill. So
Oh,
it's not like when they're speeding, it's when they pay their fine.
okay. And then, so inflation and budget issues and may.
Yeah, because we looked at this and how COVID impacted it, right? And we expected to see a decline, but with less cars on the road, people were flying at warp speeds going to work. So we actually counterintuitively saw an increase. So it will be interesting to see with the,
Sure.
inflation and the things that are happening economically right now, how that plays out. So.
It doesn't appear that we're in jeopardy of having to adjust our budget because of this. Do we have any contingency for that or it's not on our radar?
It's like I planted that question in you, Dr. Bleacher. So, because they put into our trust for FY '23 what the last year's funds essentially were. And remember, we do still settle up at the end of the year on the fireworks excise revenue, which is now slightly over $1 million. I haven't asked the question, what happens if we're in a shortfall? I don't want to know the answer, so,
But it doesn't seem like we're in jeopardy of having to deal with that.
Oh,
no.
we're close. I mean, we're right on, we're 2% above, so, we'll have to wait and see.
And fireworks should be.
But
about $1 million.
fireworks
Should be the buffer
would
zone.
potentially buffer that, yeah. So it's probably a conversation in my next meeting with the governor's COO. I'll just kind of broach it a little bit because she seems very practically oriented about how this works. And she's the one that actually set up the trust fund, worked to set that up for us, so, and worked on the legislation for that. So. All right, and I just put a note about strategic planning, a little bit different this year. They want the plans by July 11th, which caused me to have a little bit of chest pain, but on the next page, you'll see they've really streamlined the format and it's in Excel. Our environmental scan will be largely unchanged. And if you recall from the strategic plan revisions that we submitted a couple years ago that were largely unchanged last year, really the focus was shifted internally on service levels, ensuring payments, tracking things like finances and fund expenditures and ensuring we're sort of maximizing our budget. And focusing less on the big system things that we as a commission should probably keep separately in terms of like system initiatives, but this really focuses on the things that we kind of have direct control over, if that makes sense. So I just put this in there to kind of give you a heads up that that was coming up, and I'll probably submit to you once we're gonna have a team meeting where we're gonna kind of drill down on this, and then I'll send it out to you all. And whatever we send is like preliminary, we can make edits to that. They're pretty open about this. We used to be sort of a rigid process. We typically submitted with budgets on or around Labor Day, but this year is a little bit different, so they kind of snuck that in there, but much more to come on that. And then in your packets, I've also included in February, the Trauma Center Association of America did their annual virtual Lobby Day event, Lobby Day Academy, and Lobby Day, which was very successful. I think this is the second or third year now that they're doing it virtual. Do you remember, Virginia?
This is the second year they've done it virtual.
Virtual, okay. And I think last year, there was a lot of trepidation about how will this work, because we're not in front of their faces. And you know that FaceTime with your legislators, as we've all learned, is so critical, but it was overwhelmingly successful. And it was, I would say, the same this year. I welcome your comments because you were part of my team, of our team for Georgia.
Yeah, it was very well received. Last year was the first year. There were some technology glitches as all of us were transitioning to the virtual world, which they had completely ironed out this year. I think the legislators are used to doing things via Zoom as well, committee meetings and so forth. So it was pretty seamless. Cheryl and her sister participated this year as well as our trauma survivor from Georgia. And that's really who they want to hear from. They don't really want to hear from us at all. They want to hear from their constituents and the impact that the funding has. If we had the ask of, we thank them for the $5 million for Mission Zero. And we ask them to pass and appropriate funding for the trauma system grants. So with follow-up letters from us too. I sit on the TCA Advocacy Committee. They have a great lobbyist group. They keep us well informed of movement of legislation and things that are going forward. So it was very, very successful. It's a lot of fun. I encourage anybody to participate. Don't be intimidated. If you've never done it, you can kind of lurk in the background and just kind of experience it and see what it's like. So to build your confidence for the next time around. But it is a really great opportunity. This is at the federal level. We've been doing this at our own internal state level for quite some time. So it was kind of interesting to step into deeper waters at the federal level. Cheryl, do you have any comment, not to put you on the spot, but you and your sister were quite, your sister had to talk a lot.
Yeah.
We had meetings all day.
It was a great experience. I was one of the people, since this was my first time participating, I worked in the background, as Regina mentioned. But it is eye-opening. I learned a lot. I think it's also very encouraging to see how many people are out there advocating so that we can get the funds that we need in order to build the support trauma system. So I would definitely encourage you to participate next year. And my sister participated because she is a trauma survivor. So she was able to share her story. And probably 60% of the sessions we were in on that day.
Yeah, her bio is in there too, if you want to read a little bit about Radine's story. What I was stunned by is that she had an aortic dissection, which is like unsurvivable. And the fact that she made it to the hospital alive and got her interventional procedure and survived it. And it's so impactful to the legislators because they look at Radine, she's not one of us in the profession, she's one of them, so it can happen to them. And the calls were really nice. The way it went was we just did a brief introduction, and then we started with sort of the survivor story and how impactful it was for them to actually get to the resources of a trauma center. And like Radine talked about the EMS folks picking her up in the field and what that meant to her, and then like sort of talking her through it. So it was really great. And there's some nice bullet points in here. If you're not familiar with either Mission Zero or the, as we say, the very less sexy bill, the Improving Trauma Systems and Emergency Care Act, they're going to come up with a better name for that one because that's unsellable with that name. They're both in there and there's nice talking points on it, and Trauma Center Association of America website has very detailed information on both of those, including all of the letters. I have much more information I'm happy to share, but I didn't want to overload this already full packet, so.
We had a picture, a screenshot. Of
Yes,
our
a
Zoom
screenshot
room.
of our mugs
Our
on
Zoom
the,
room.
on the Zoom call. We had participation with all the legislators or someone from their office, so it was really great. All right, any questions or anything on the TCAA day? I included the cover of the new resources for optimal care of the injured patient. That was something that we've all waited for what, 7 years now, I think. So it's finally out. Unfortunately, all of the level 4 criteria, level 4 trauma center criteria was eliminated from the book. Now, the ACS COT has heard this loud and clear. I was actually on a call with Dr. Nathans and Dr. Nilda Garcia, who's the VRC chair. They recognize this was a major oversight, and so they will be adding it back. They don't know how they're going to do it. We're actually asking for our recommendations, which is sort of scary, but they don't know. They don't want to have all those iterations published in clarification documents and all those sort of things. They want to make it easier. So we'll see how that gets incorporated. I think the thing that will really help that, and we'll talk a lot about rural because that's a huge focus of what we're doing, but the ACS COT has stood up a rural committee that's actually comprised of rural trauma care providers. It's not level 1 academicians sitting on a rural committee telling the rural centers how to do rural trauma. So they actually have some good rural representation on that. And it's multidisciplinary as well, which is really nice. So in addition, not really well advertised, but the ACS released the national guideline for field triage criteria. You all probably know this as the CDC field triage criteria. So that was released as well. And I would encourage you to go to the ACS website on that release. And I'm not sure if my on here includes a link of it or not, but we can put it on our website for folks, because all of the literature and the meta-analyses that went into updating these criteria and how they did all of that is included, and it's pretty stunning, the respondents. I know it seems like when you don't hear a lot about it that it was done in a vacuum, but it really wasn't. There was a lot that went into this. It's been many years in the making, so I'd encourage you to take a look at that as many folks move forward with adopting the new criteria. And then we mentioned already that May is Injury Prevention Month. And again, in the spirit of trying to provide you with as much in the way of resources that we can, American Trauma Society really, I think they're the organization, the Society of Trauma Nurses does as well. They link a lot of stuff to American Trauma Society. They have a lot of resources. This year, theme is really safe surrounding, and it's about that violence prevention piece that we know really kind of crept up over COVID. There's also a National Trauma Survivors Day toolkit, which I'm dreaming of us sort of getting involved in a trauma survivor, especially since it was so well received with the Federal Lobby Day. So I put a couple of those things in your packet you can take a look at. And then, excuse me, we'll move along to the last couple of things is the consultative visit program that the commission is funding for the level 4 visits. There's a PowerPoint in your packets that describes how this, for the level 4s, it was the education that was provided to them in order for them to be successful with their consultative visits. So the way Pennsylvania does their visits for their level 4s, they have an online PRQ. Well, they can't do the PRQ. Their registry is actually connected to their PRQ. How nice is that? But it doesn't talk to our registry. So they're filling out a regular old paper PRQ like in the old days. So they did a couple, they did a couple sessions with the centers to kind of give them an overview, talk about the timeline, when they should get everything in, give them an idea of the schedule for the day, who the survey team members are. I'm really excited too with this to say that both of the physician surveyors are level 4 ED physicians who are in level 4 centers, doing it, running it every day. So it's, again, not a trauma surgeon coming in. Not that I'm talking bad about trauma surgeons. Sorry, boss. But for the level 4 piece, because those programs are driven by ER docs, it's really imperative that they get that feedback from on the colleague level. So we're really excited about that. Both of those survey members happen to be PTSF board members, and one of them will likely be the one that comes in November to do the aggregate overview of strengths, opportunities, and recommendations. And that'll be a 1-hour presentation inclusive of 15 minutes of Q&A. So again, the reports are the centers for them to own. We're not getting them. We don't want them. That's for the center to learn about their opportunities. But what we wanted is, since they're going to look at 6 of our centers, or at least 5 of our centers, we wanted kind of an aggregate overview of what their findings were, given their expertise and how mature a lot of their 4s are, what they thought would be some recommendations to invest in for the future. And it's nice because November, the day that we have our commission meeting on 3rd Thursday, always coincides with Rural Health Day. So it would be really nice to have a rural health focus. And in fact, we're already talking about potentially moving that meeting up to that Macon Marriott that we used to do our own meetings at. Remember that? Because it'd probably end up having to be a full day meeting. We'll have to put lunch in just because PTSF is going to be an hour. And now we have, our committees are so full, and with TMD committee standing up, we're going to have a lot more reports. So.
Liz, what would be your recommendation from a committee standpoint, from a trauma commission standpoint? Would it be helpful for us to be there during that initial visit by PTF from when they're meeting with the level 4s in October, or should we just not be there because then that's a little uncomfortable for the centers and it's best just to hang out at the commission meeting and let them give their overview? What would be, do you think, the most helpful?
Thanks for asking that, Dr. Dunn. I really think let them have their visit. This is no different than the ACS doing a consult visit for a 1, 2, or 3. So that's their time with the surveyors to learn about what's going on in their center and how they can improve it. And then I think when they come to do that discussion with us in November, I think that's your time. And hopefully, especially now that we move it where we can have it in Macon at that nice facility that can accommodate, hopefully we can try to get as many of the rural folks there so they can kind of talk about their experience and what their barriers are, because they can make recommendations to you, but unless we can understand more about the barriers to implementation of some of those recommendations, then it's going to be hard for us to figure out how to, at least we now have, that level 3, level 4 group formalized. So through Dr. Register and Dr. Patterson's leadership, we can now get better input from them.
Right.
And then also we'll talk about this a little bit later on when we get to Dr. Patterson and Dr. Register's group, the level 3, level 4 group, but the rural focused visit potentially in January that I think it just all is going to flow really nicely.
So which folks have the opportunity to interview the EMS people in the community?
Which one? The PTSF consult. Usually it's customary, and it's probably too small on here, but usually they ask you to invite someone from your EMS community to be at that group meeting. And I think
Courtney brings up a great point. Absolutely. I think EMS has to be very well represented at that meeting.
I mean, you were at your state survey, so I think you'll, yeah.
I'm a hospital employee.
Yeah.
So there's this barrier, it's called ER goals, and. they
They don't let you
change
through it.
something. So I would encourage the boards to bring their EMS people.
I think that would be a great point to bring up at the level 3, level 4 committee, so they know, so they hear that, that you should invite your EMS personnel. Yeah. The whole continuum.
I have to say, the packet of information and education that they do is very impressive because it definitely helps set them up for success. And walking them through the steps and things, which is nice.
And with them having ER docs, level fours, they should be able to speak the same language very quickly with EMS. So I think y'all need to do that.
All right. Okay, and then just to wrap up, unfortunately, many of you received a malicious email that went out on behalf of us. They really caught us at a bad time, which is apparently what they do. On the Thursday before a holiday where state offices were closed on Friday. So that sent off a whole slew of downstream events, one of which was the rapid deployment of our .ga.gov email address that we had been trying to get for about 8 months. And it only took one phone call to get that fixed the day of your EMS committee meeting. So that was wonderful. And so we will be deploying that soon, and we'll keep you all updated on that. And there just was some additional recommendations around cybersecurity training and multi-factor authentication for several other applications that we use. So I just kind of wanted to throw that in there as like a loop closure on making sure that we're doing all we can to prevent ourselves from an attack like that. Luckily, we switched our website over to GovHub back in the fall. So so that was one potential vulnerability that we closed. And then just a couple other things not in your packets, but I just wanted to mention the EMS equipment grants. I think there were only maybe 4 services out of 178 that did not participate this year. So very little funding left over, which is really nice. So I think we want to make sure that we're consistent. Katie and I talked about just having that timeline be really consistent with when we open the grant, when we close it, so that it's predictable. Every year folks will know, oh, you need to go to the commission to get your money, because we don't want to hold on to that money. We want them to have that money. So great job with that. And then I already mentioned, but just prepare yourself for the November meeting, because it's probably going to be an all-day thing with that, with PTSF joining us. They're flying in, like I said. So they're board members and their team, so they can kind of talk to us and give us their feedback. And I think that will probably elicit a lot of dialogue from us, and hopefully have all the World folks in the room as well. And it will be the prep for if we have our World Focus visit in January. It will be a good, like, sort of last meeting with everyone together before we do that.
I got a question, Liz. Going back to the budget, are we privileged to find out who does the majority of the super speeder laws? Is it state police? Is it local? And what areas of the state? Do we have any of that information?
Not on the information that we just get, like the spreadsheet once a month that we're so happy with. And like Katie said, which is a great point, that sheet is just the revenues. That's the month they paid. Doesn't necessarily correlate to when the event or the ticket.
The reason I ask that is because I've not met many state police or state patrol that do not know where the super speeder law actually goes to. But I've met many of the small jurisdictions that have the older persons that have not been through the academy in years. They do not have a clue as to where we are or where the money is going. And once they find that out, I never turn out an opportunity to do CPR, either stop the bleed, just so I can get a chance to tell them where it's going. And once they find it out, many of them will come up and say, I never knew that. I wouldn't write. I've seen many I could write, but wouldn't do it because I thought it was just going to the Capitol or to a Georgia fund. But once they find out, they tell me, I'll be more diligent to make sure that that's done. So
That's a great point, Vic. I think, and I've heard the same thing, like from officers, but I just talked to them on the side and conversation. I really didn't know that. Wow. And those might have been state police as well. So I don't think it's just local. I think it's global. This is an open question to anybody that knows the answer. I'm willing to go I'm sure all the commission members would, to a police
Training day.
training day or banquet or whenever they get together for their yearly thing and say, and thank them personally and show them a few things that we do and what their hard work has resulted in, because they don't see. I don't think there's a connection. They see all the lives that are saved and affected by what they do. So how do we get the word out? Who do we go talk to? And I'd rather not just do an email. I'd rather some FaceTime to thank them. But I don't know how to do it.
They have training, they do the training, and their biggest one, of course, is CPR, and particularly Stop the Bleed now. Stop the Bleed's the easiest avenue I've been able to use to go inside their departments and chat with them, one-on-one.
Are there countywide or statewide training conferences?
It's all three, it's the Georgia Association of Police Chiefs has a conference, Sheriff Association has a conference, and then one that they all kind of go to is the highway safety conference. The highway safety folks, the vast majority of their money goes to the law enforcement. So they show up.
Yeah, that would be the biggest
problem. Probably maybe that would be the better.
Which one's that?
It's the Georgia Office of Highway, Governor's Office of Highway Safety.
Can we get 10 minutes on that with some slides to thank them? Is that possible?
Yeah, they, quite frankly, I think they would, I suppose, quite a few years ago.
Liz, why don't we start working? How we make that happen?
Yeah, and I used to present the budget with the public safety who's over the state trooper, and I always used to go up, at least make sure that he knew who I was and who we were and how it benefits us, but like, there has to be some level of formal leadership thing, so.
Well, there's a police officer that spoke at our trauma day a couple times. Brian something or other, very, very excellent speaker, was the part of the governor's office of highway safety. And then he spoke at our ACSCOT Georgia meeting a couple times. But I think they have a key representative on that governor's committee, and that's part of the first thing. Okay. There's some research opportunities too, if we could get the data to find out where most of the speeding is occurring, and then see if we can correlate that with, accidents and traumas and transportation to level 1 centers. There's some research opportunities there as well. Very good.
Good.
That concludes the report.
It does, thank you, sir.
Okay, thank you. Dr. Maderos, we'll move into the budget committee report.
Thank you, Dr. Ashley. Our budget committee report, we very brief this month. We had a called meeting to pass the FY23 operating budget, which was a full budget of $20 million, which was very exciting. We are about to take up discussions on the FY24 budget, as that will be due on September 1st. And our grants and contracts work group has concluded their recommendations for updates and changes to the existing grants and contracts that we have. One-page summary has gone to the budget subcommittee. We'll be discussing that at next month's committee. Any questions for the budget subcommittee?
Wow, that was short.
Well, it was a quiet month.
It'll get longer, I'm sure.
Thank you, Dr. Patterson. Next, this has got to go.
Yes, that would be fine. So is he on the
Yes.
house? Whatever. Dr. Patterson, I hear you're out there in cyberspace. So would you like to go ahead and give your report?
Yes, sir. Thank you very much. I appreciate being allowed to give our report from our most recent level 3 and level 4 subcommittees. As you see in our minutes, we've completed our cost of care survey, and this has been accepted for a podium presentation at the AAST meeting coming up in September in Chicago, which is very exciting for the state of Georgia to kind of lead the way in level 3 and level 4 trauma cost of services. Going on to our center consult process, the level 3s have all have consult visits essentially scheduled. And those are progressing, of course, kind of delayed a little bit due to the COVID pandemic and the ACS over the last 2 years. Our level 4 process that you approved previously through the Pennsylvania Trauma State Foundation will be happening for the state and all the level 4s on the week of October 10th through the 14th. There is an orientation call that we'll be having that's actually included in your commission meeting packet today. Our grants and capital equipment and educational processes, we're proceeding with our development of the Georgia March Pause Initiative, which is in the process of ongoing development in conjunction with Courtney Terwilliger. We hopefully will have some major advances by the time the August meeting rolls around. We have several things coming up both in June and possibly in July or August, so we can get everything done as far as the March pause. One of the questions that was interesting raised the other day is how is this different from the rural trauma development program that the ACS did? And what we're really trying to do is that was taught by level 1 trauma surgeons to the rural center. And ultimately what we want to do is to have something that's taught by the other rural centers to the smaller places in rural Georgia so that they can connect faces with faces and ultimately, you know, see those people as people they can refer patients to and hopefully improve, you know, their relationships. As far as access to specialty care, currently the level 3 and level 4 committee is working with the administrative subcommittee, and they're going to work on the process of diversion and improving diversion times for rural centers out there. Our IRB that we wanted to look at for rural centers is still tabled at this time. I'm going to skip ahead to our agenda item number 7. Our PI project specific to level 3s and level 4s, we've actually tabled until we have the Arbormetrics launch so that we can use the information specifically from level 4s that Arbormetrics will allow us to capture. Sorry, I have a new Apple phone and it's not working the way I want it to with my notes on it. So I do apologize. The only other thing I did want to ask for was our quotes for our ESO web-based project will need to be, we want to bring that to the committee's attention and ask for a potential funding for the ESO quotes that you have in your meeting packet with you. This will do a lot for the level 3s and 4 centers to go to truly web-based registry and will help them essentially get caught up with the other centers in the state of Georgia.
I'll add to that, Dr. Patterson. We got an updated quote to include the PRQ report package for level 3 and then a custom report package for level 4 since the PRQ is a little overkill for them.
Right. I apologize. I forgot about that.
Oh, no, that's good. I mean, you probably haven't seen it because she just sent it to us yesterday. So,
Sure.
So we wanted to wrap that all up into it if we could, because we already, the commission approved the web hosting as part of the amended budget. So I forgot, we actually do have a placeholder for that. And based on what the centers already get for their registry support, we would just have to include the gap, if you will, which ends up being a lot less than what we originally thought. It's about $57,000 or $60,000. So I think with the placeholder of $80,000 that we have, we can give them the additional money through amended process to get up to the web hosting and then also purchase the PRQ package for the level 3s and the level 4s. If we go a little bit over, we can pull some from the contingency. If we get a little bit under, we can always keep a PO with ESO. Katie mentioned that we pay them anyway, so.
Sure.
So that's a question.
So is this for them to do their primary entry for registry in the web-based system?
It's for all of it, includes outcomes module.
So you know, we already have that in our system, right, for free, that they don't have to pay anything additional? for that.
Yes,
And we have the PRQ reports already done. It just seems like that's a lot of money to be spending on something that we already provide.
I think we have that. We'll talk about that a little bit later with the.
Yeah.
SQL piece.
Liz, just a terminology question. ESO and DI, are they the same thing or? what is it?
ESO bought DI.
ESO bought, yeah, that's what.
They bought three of the top three. It's really, I think the only registries left are ESO, Image Trend, and then I think somebody else is trying to get into the market.
Okay, okay, because yeah, I mean, DI has been, you know, everywhere I go is where DI is, so.
Yeah.
Okay, that helps.
It's now ESO.
Yeah,
So just replace DI with ESO wherever.
it's an extra letter, though, come on. Right.
They're stretching your alphabet.
Okay.
One final thing, yes, sir, one final thing, and I'm sorry, I forgot about this, was the combined, we would also like to ask for funds to allow for the January ACS Rural System Consult visit, which would be coming down to visit visit a majority of the regions in Georgia to do a consult visit for the whole state of how the level 3s and 4s tie in with the level 1s and 2s, and ultimately the state, how it functions as a trauma system from a rural perspective.
No, so the date would be January 9th to the 13th. The ACS came back. Dr. Patterson and I and Renee have been on several phone calls with the ACS on this like rural focused visit. Again, it fits nicely with all the rural initiatives that we're doing. And I confirmed with them, they will actually be on site for one whole week. And it will primarily be in the South Georgia area, although we can't forget we have some rural areas up in North Georgia as well.
Right.
But I need to confirm that date because they're holding that because it's a whole week and it's a lot of people they have to get together. We do already have a placeholder, we've had a placeholder in the budget almost every year,
Right.
at least that I've been here for the full system consult, which was awaiting the NHTSA eval, but,
Which is going to be at the end of August for right now. That's the tentative date.
okay. But I
And
think
how long
it's,
is that visit? Or
It's a week.
it's a week? And then when can you expect to have a report back?
So we'll get a verbal report at the end of the week, but the official paper report will come within a couple of weeks. But that's a very short time from that to another, statewide system visit. That might be best.
Yeah, because the
Put that off
ACS
a
the
little bit.
report doesn't come right away from the ACS. It's a couple, 3-4 months sometimes before you get your final report from the ACS for complicated issues. So this can turn them around faster. That's great. All right, thank you.
So when they came before their public hearings, is that where it's going to be set at this time?
Liz, do you know where South Georgia is going to be? Are they going to stay at one facility or are they going to travel around?
it's not facility based, because they look at everything.
Right, yeah, so where
yeah.
are they going to be?
I really, right now, we're just in, they wanted like a framework for
Yeah, so
questions.
they've never done this before. so
Yeah,
we're
no,
trying
they
to-
want to use.
They've never done that.
Yeah, yeah. And the rural committee did vote for it.
Oh, yeah, I think we're all in favor of it.
Yeah.
Sure.
Okay.
Yeah.
We need a motion to do that, or we could,
I think I would like I think we probably should get a motion to approve the date so that I have some legs to get back to her and say that we've approved, the rural committee's approved it. It just, they had their meeting after the report was due.
I would be. I said, to approve that. So, is that what you need?
Okay.
And what's the date?
Can you hear Greg? Sorry. Can you hear what's going?
Yes, sir, I think so. Yes, sir.
Okay, if you can't hear, just pipe in. I don't know how loud the owl is.
So I can hear you.
You're so sorry.
Well, Courtney is so genteel.
Dr. Ashley, can I bring up something?
Yes, David, go ahead.
Since we are having the NHTSA visit so late in the year, I mean, it is, last week of August, first week of September. Do we think that pushing a January additional visit is kind of close together? Because it doesn't really give us time to absorb what the NHTSA visit does, which of course they will also look at the trauma system. That just seems like an awfully short amount of time between that and another statewide visit. Seems like we should delay that a little bit so that we can again absorb whatever NHTSA finds when they come and do the visit.
Actually, when we originally thought of this and tried to look toward we were almost trying to do the same date in October. The original NHTSA visit was scheduled for October, if I remember correctly. And they could not really get all this stuff ready from the ACS standpoint until January. And then with them moving with the NHTSA visit from the end of August to 1st of September actually gives us more time than what we originally thought. I really think they should be able to get the report in, especially since the NHTSA visit is not really concentrating on the rural level 3s and 4 centers and how they interact with the level 1s and 2s. I still think this is enough time to do what we need to do to digest the NHTSA visit beforehand and then incorporate that in with the visit with January with the ACS.
If I'm wrong, but when you guys helped ACS develop this agenda, because it's never been done before. And
Right.
so I think Liz and Regina and you, Dr. Pedersen, have done a great job in trying to come together and figure out what a site visit would look like and what would be helpful, what wouldn't be helpful. And so I think you guys actually put together what the agenda would look like, kind of what the PRQ would look like, if you will. And I think Regina sent me that PRQ at the time, but
Every timing, sorry.
yeah, so just how much of that PRQ is rural EMS? Is that a big focus or is it a little focus?
I can pull it up. It's an 11-page PRQ. That's what
Yeah,
we're
so it's
talking
not
about
a
little bit.
65-page.
It's not a 65-page
So it's much
PRQ that we
different.
fill out. And it's definitely something that needs to have Greg, I would suggest your rural subcommittee get a multidisciplinary group together to complete the PRQ.
Right.
And then different documents and so forth.
Yeah, I thought the PRQ was for that site visit is completed by the Office of EMS and Trauma.
It doesn't have to be. We
Right, but that's
had
been
we had a consult call with them, long before, we were talking about the global Georgia evaluation, having them come back and do that. They encourage a multidisciplinary, just like we do. It's really designed from a systems perspective, just like the center perspective. So for those of you who are familiar with getting prepared from the center's perspective, we always have large steering committees which work, each area has their area of focus on the PRQ, like you've probably done it, right? Or
Yeah.
everybody has theirs, EMS and pre-hospital have their section, ortho has theirs, and then everybody works on it, gets together, and then there's usually somebody who coordinates and puts the pieces together, puts the finishing touches on it, polishes it off and sends it on. So that is really the best practice. We've only done it once here. So we only have limited experience with the system, but they prefer it to be a multidisciplinary, larger.
We did that, thought it was supposed to be submitted by our office.
It has to be submitted by whoever the requesting agency is.
Right, but I thought the request has to come from the Office of EMS and Trauma.
I don't believe it has to. I do think they have to participate and be involved and support it, but it doesn't have to be submitted by that. That's what she said when we
Right.
talked with
We
them.
should probably discuss this offline. I just want to make sure we're good because again, we're having to prepare a lot of stuff for the August visit. Without having much time in between those visits, do we really want them to find the same exact things that we just found a couple of months before on something? I'm just saying it
I
it might
think
be
the-
better to.
Based
postpone
on the
it.
questions that we formulated, that Renee is included on those emails, a lot of them were just around best practice with rural, and I think, and Dr. Patterson, Dr. Register, Courtney, myself and Renee postulated those questions. They were really well outside just the EMS scope. So as Dr. Patterson said, I think it will glean so much more for them. And again, the timing, I think, is really good considering that it just be a few months after the level 4 visits.
So-
And then, yeah, you'll know something from the NHTSA visit. And a lot of what you put together for the NHTSA visit will probably comprise anything that you would have to put from an EMS
Exactly,
perspective
that's
in
what, yeah,
the-
there's this. it's
in the
not-
PRQ. And, you know, we had already talked about that we could potentially meet at Core Deal because the State Office of Rural Health is there and get all the actual stakeholders, rural stakeholders in a room together. And again, do the PRQ together really is probably the best approach. I just don't see a hard reason to kind of put it off. Is it busy? Yeah, but we're all busy. And I think the benefit to rural with so much focus on it right now would really outweigh the, you know, additional effort.
When would the PRQ need to be submitted? by?
It's usually like your visit a month.
Oh, just
ahead
a
of
month
the-
before, okay.
Yeah.
Oh, that's, yeah.
Usually, I mean, I don't, again, we're just in the
Yeah.
postulating the questions
Yeah, right.
phase.
Yeah.
and-
The nice thing is we get to kind of gear this to the benefit of the rural centers, which is nice.
And you're right, there isn't gonna be any ideal time.
Yes,
I think some of the idea behind it, from the rural subcommittee, and Greg and Kelly jump in, was there's so much momentum
Right.
with that solidification of that group. They're so cohesive at this time and engaged, that they're very interested in building on that engagement and
Right.
getting some feedback on how to better enhance the
This
system.
is the, you know, the iron is hot,
Right,
you got to straight when the iron is hot. for sure.
exactly.
and so I found the email where we formulated the questions, and a lot of them, again, are about regional, territorial, rural best practices. What does it look like in other areas? And as they look at kind of what they see in the PRQ, how does what we have set up compare to those other areas? And then also things like, you know, waivers for specialty, because there's a lot of capability in South Georgia, but it doesn't necessarily fit within the levels of trauma center requirements when you look at a gray book. And say, for example, Pennsylvania has, you know, you and I have thought about this every year. So like, you know, Pennsylvania has a way that if there's one thing you're missing from one, it doesn't stop you from being part of the system. And then to dovetail on that, what does successful incentivization programs look like to get acute care facilities to participate in the trauma system? Because we're kind of dichotomized. We have, you're either in the system or you're not, but we don't have a lot of control over those centers. And Marie and Gina and Renee and I are looking at a lot of, Dr. Ashley just moderated a session this morning on whole blood and transfusion practices over the last 150 years. And we have a lot of crystalloid being dumped on patients before they come. So they're not even viable when they get to the trauma center. So we know we have a lot of opportunities there. And then for level 4 centers without surgical capability, some things about competency and how that's done in other areas, how that can be applied to our areas. And then and then there's some EMS things like around blood, pre-hospital and interfacility. And then, you know, we have a problem in South Georgia when helicopters can't often fly. You know, that's like, it would be nice to use a helicopter, but we can't. Yeah, so lots of things around practice, competency.
So I made a motion to accept them, to move forward with the dates, but I haven't made a second to do that.
Awesome.
I second. Yeah, I think it's great for the state, all three of those, the NICSA, the ACS, the PTCS. Fantastic.
Okay, so open for any further discussion. We have a motion. I think to answer David's question, I think there might be some trepidation about the time, like you laid out the timing. It's my understanding, which I think is a very good point. I think from my understanding, it sounds like this should be a team effort with the level 3 and level 4 committee doing some heavy lifting to get that data, you know, filled out. So I don't think it's fair to take your point, to drop that on your office to say, you got to do this by a certain amount of time. I think the idea about getting stakeholders together and producing the documents, and it's never been done before, would be the most expeditious way to go and make it easy for everybody. I think the goal is to make it easy for everybody. Sure. And I think coming from our rural committee, which Dr. Patterson and Dr. Register has done such a great job of pulling people together and energizing people, I think think we can get a lot of work done there to where nobody feels the strain of this. So I think hopefully that will solve or help your office, David. We don't want to put anything on your office, that stresses the system. So.
And David, it might be helpful if you could send me or send the commission a copy of what the PRQ for the NHTSA visit would look like, what data you have to get together and what have to pull.
Yeah,
And as we develop questions for the rural site visit, we may be able to tailor some of those same questions that you've already pulled for the NHTSA visit. I just would be curious as to what data you're going to be pulling for the NHTSA visit and how that would dovetail into the rural.
That's
So,
great.
that would be,
Together.
yes, ma'am.
Collaborate.
And I just want to say, I don't think it's as much as we're concerned about the workload for our office. We're kind of concerned that whatever comes back from the NHTSA visit that needs to be addressed, we as a state won't have time to do it before the ACS visit.
Well, I think from
That's our
that,
concern.
I think from that standpoint, we'd have to delay the thing for 2 years because the things that come back from NHTSA is going to keep you busy for 3 or 4 years,
10 years,
So-
more information, more data.
because and that's what those things do. They come back with a lot of suggestions. So I don't think we have to have things corrected. It's not like we're gonna get in
No, I don't
trouble.
agree, correct.
I think we
It
just
takes a
use the
while.
same data and say, this is where we are.
This is where we're at, right?
But then we'd have the rural thing, the NHTSA thing all together, and we'd all have a lot of things we could work on. So.
Right.
So just a question on my part is, if that NHTSA report comes back that shows legitimate things that we as a team need to work on and at least start trying to look at solving that could affect the ACS, would it be possible to delay that ACS visit if
Right,
we,
so
as a team, found that?
I think you
on
have to,
that-
go ahead, no, I'm sorry. So I don't think the ACS visit is a pass-fail visit. That's not what this visit is.
Okay.
It is how can we give you suggestions to improve your system kind of visit? It's more like a consultative visit than it is a pass-fail visit.
Right.
So I'm not worried about, and maybe I'm wrong on this, but it's not,
No,
I'm not
No,
worried
there's
about
no,
failing.
I
this.
actually sit on the committee for the ACS COT systems.
Yeah.
There is no verification for systems right now. This
Right.
is
No,
strictly
it's just
a,
advice.
how can we help you?
Right, yes, exactly.
So we
It's a
would
consultative,
actually-
how can we help you get better visit?
Yeah.
It's not like,
Right, and
But
the
where I'm
NHTSA
saying,
visit
I'd
is
like
the same
to-
as well, right?
Yeah,
And this is not a pass fail. We're just saying if they were to find something. I guess our point is, do you really want 2 system visits to find the exact same thing within just a couple months of each other? It seems like that is not as useful as, well, let's address some of the things. And then, I don't know, 6 months, 9 months later, we come back and have we made any improvements in that? And the ACS would then come.
I think from what we're looking at with the whole hospital piece is, the NHTSA is going to be just one piece of what we're looking at. So even if we corrected everything in there, we're still going to have a lot of things I think we're going, and I expect they're going to give us a lot of things we need to work on. And that's what we wanted to do. I just need somebody to say, you need to do these 20 or 30 things and guide us. So even if we had NHTSA perfect and we corrected everything, we're still going to have a lot to work on. So I sort of hate to delay to make NHTSA get those things out of the way, because it's not about looking good or trying to correct things. It's about just, and if they tell us the same thing NHTSA did, like, well, yeah, you need to work on it. Yeah, we know that, but tell us the other things that NHTSA didn't tell us. We need those to work on too.
Or it's a
So,
verification. It helps verify the priorities that we have
Right.
right now.
Right.
Let's face it, we're there, NHTSA's gonna find issues. We know that.
yeah.
And so is the consultative visit. It just provides data and information for action planning. And hopefully from a budget committee standpoint, priorities for appropriations of dollars. If we keep getting the full super speeder, it's better to have informed decisions around dollar appropriations than that are data driven
Yeah.
versus, I don't know, let's give this.
And I think similar to
budget
your
money.
center ACS visit, you know how you often see in your report, like they'll reference your NHTSA, they'll say, XYZ noted as weakness, NHTSA consult identified DPH OEM S&T already had, or developing process or has put in place. They'll mention that,
Right.
which is kind of nice because then your initial plan, they can give you feedback on whether they have additional recommendations about that.
Right.
And
Plus,
then
I
the-
think if they say, if they back up NHTSA, now we have two folks or agencies saying you need to fix X. That gives us more firepower to get things done, I think, so I'm not worried about looking bad. I'm just asking for help, like, please tell us, and then we can go to legislatures and say, hey, we've been verified by two folks that say this needs to be fixed. We need some money to do it. We can go ask for it, so, or fight for the money, the fund.
So is the NHTSA dates now hardwired? Is that set?
We're waiting on them to confirm the site visitors.
The dates are set.
Again, we're waiting on them to confirm the site visitors. They don't have the site visitors, we don't have the dates. So as soon as we know that, we will let them set.
Great discussion. Very good. Very thorough. Okay, I guess we need to call the vote here. We have a motion. All those in favor? Aye.
Aye.
Opposed? Okay, Greg, can you, I see your picture there, you still here?
Yes, sir.
Okay, Liz just stepped out for a second, so, anything else on your report?
No, sir. I appreciate the time.
Okay, thanks for what you're doing. You guys are doing a great job, and we, really appreciate all the enthusiasm in the rural committee and level 3, level 4.
Yes, sir. Thank you. We appreciate it, and hopefully we can keep it going.
Okay. All right, we'll move now, Courtney, into the EMS report.
So you got this month is on page 67. We moved 10 pages back, so back to there. So you got the information from the committee, but just to keep a review. We're meeting next week with the EMS subcommittee, one to look at the budget that the trauma commission's given us and try to figure out exactly how we want to spend those dollars. It's also going to be a little bit of a review of what we're doing. Because there's some things that kind of vex me. Working with level 3 and 4 centers and working with some other folks. I keep getting this information and it comes enough that I think is valid that ambulance services in rural communities are not making critical or time-sensitive transfers to tertiary center. So I'm trying to get a handle on that. I'm trying to get some actual information. It's been very difficult to do that. The point is, if as a trauma commission, we're giving money to services in the form of equipment grants, and they're not taking care of trauma patients, I don't want to give them more money. That's right. I actually was on a conference call yesterday with the leadership of the Association of County Commissioners in Georgia, and I brought this forward to them because many, if not most, of those in rural Georgia really can't run an ambulance service without a subsidy. Look at what we've looked at with the readiness costs for a hospital. With EMS, you have fixed costs there, which I think is the same thing. I'm not completely sure of that. But unless you have a high volume of service to bring money in to go against that fixed cost and lose money, and they always do. And so they're subsidized. So the county commissioners control that. And I've seen contracts. I'm trying to get one of the areas that I got to complain about. They're going to give me a copy of the contract that the county has with the private service that runs for them. So I'm interested in seeing if indeed some of the counties have, and I've seen some of them, have a contract that says X number of ambulances will stay in the county at all times. And they do that, I think, to make sure that they have ambulances to run 911 calls. The problem lies in if you're leading to death because you're in a car crash and you ruptured your spleen and you're not in the ER and they have to have one ambulance sitting there, that becomes a problem. So as we talk about the people, the players at the trauma field, we talk about the surgeons, the hospitals and the EMS, but quite frankly, the commissioners are part of that plan too. So I opened that discussion with them yesterday. That one that I've heard so much about, the county government just got the zone, and they just contracted recently with this provider. So I'm trying to figure out, and they're going to get the contract. I know that particular issue is true. Well, I brought it up at level 4 centers, meeting of them and asking, I'm letting them know, because I'm trying to quantify it. Because again, we have a hard time trying to figure out if they have that risk of critical injury in rural Georgia, and you go from home or scene to one hospital and a transfer to another one. We have a hard time putting those pieces together, so we don't know. We don't know if it's the best response time, or if it's a hospital, or if it's a referred to. So we're trying to figure that out. I'm just trying to figure out one piece out.
So Courtney, just as you've said on the data subcommittee report, you've heard the data, you've seen the data. I think EMS community in general does a fantastic job from ditch to first hospital, whether that's the level 1 center or the rural hospital. The issue becomes, and frankly, the rural hospitals, for the most part, do a great job in contacting the next level hospital to get them out of it. But there is a significant delay from, first hospital to the end hospital. And right now, we don't know what that issue is. I think it's a lack of transport availability. It's clearly, now, why is there a lack of transport availability? I think that's what we got to dig down deeper into. And I don't know if there's in your opinion, is there a lack of EMS providers, not necessarily companies, but actual EMS paramedics and BLS providers? Are they just, can these companies just not hire enough people? Or are there just not enough rigs in the rural communities to move patients from point A to point B? And I think that's really the issue, personally.
I think there is a bit of a problem with the number of people, but the huge problem is the number of times. And that, it shows you this a while ago. And this is, for those of you that are online, it's accidental death and disability and infectious disease in modern society, the white paper written in 1966. And I've thought about this a lot. And so I've come to a conclusion. EMS in rural Georgia is working exactly, perfectly the way it was designed in 1966. In 1966, and I started in 76, we picked up somebody who wanted to our hospital. They lived down there. Very, very seldom is being transferred in the house. So that's the way it remains funded, the way it remains focused. So 911 call to a hospital, I rolls over. And we got to change that because the nature of what we do is change. And we talked a lot about the development of trauma centers, which I think we've done a great job. I don't know how to redesign it. That's why I was trying to talk with commissioners. Redesign it so that there's enough capability. Hospitals call it surge. Okay. So there's been a huge thing with emergency preparedness, helping hospitals plan to surge. But there hasn't been that much with EMS. So if you have that stroke that comes in, 20 minutes later, you got that trauma that comes in, okay, and then 30 minutes later, that's that surge. But you're not staffed, they're not staffed, they're staffed with 911 calls, right? Right. And it's that we think. And my point to the commissioners, my point to some of the legislators last year, and I hope that exact numbers do not, is that we have a joint House Senate State Committee to look at it. Particularly, and I'm so tickled with Dr. Patterson about registering the work they're doing and the work that this is spearheading and looking at the capabilities of those centers. Because if we got somebody who has that liver spleen and air spleen in Georgia, and we drive them an hour and a half to the rest of them, and that's how primary center. I'm not sure they will make it if we don't start blood at our hospital. So I'm very tickled with what College of Surgeons have done, revising that criteria, because I think they're much better thought out than before. Not saying that was bad, but you learn from what she did. So I'm really interested in seeing and trying to figure out what kind of problem got out. I have good friends who have policies in place that X number of ambulances are still in town no matter what. My comment always to them is, what if that's your child? The comment always back, oh, hell, that's good. It's probably somebody's job. So you have to change the outset, mindset of the EMS world. But we also got to change the mindset of the EMR world. And that's what I hope we can do with March policy. So that's the whole goal of this committee. Moving on, we'll be talking about our budget tomorrow with some of that philosophy in mind. Automatic vehicle location systems, we continue to fund those. One of the headaches that we've had is that people change vendors and the vendors are not the same pricing. So if they change vendors, and it's an increase, that's giving us trying to make the budget work. So we follow the Medicare plan. We're going to have open enrollment. So we'll set that up this next week. So if you want to change vendors, you will have a 30-day, 90-day window. Well before the budget time, you change it. Once you're set to next year for the next budget. So that we can make life a little bit better and plan. Okay. Learning management system. As part of the March Falls, thanks to Regina, we've tripped over a learning management platform that we are looking into. We had a conversation the other day from the Mercer Innovation Center. It's funded by the Office of Rural Health. A great conversation. So I hope to involve him in helping us develop Dr. Patterson and Dr. Register both are pushing for a hybrid course for March Falls because getting folks, particularly getting physicians to come in and listen to a lecture for 2 or 3 hours while they make rounds or do their work. So we're trying to develop that will have a good their ability to the night before, the week before, sit at the house and that part can learn online. So we're hoping that contract with this gentleman to help us do that job. He's a PhD guy, has been working with him, I think. I'm not sure how much longer he's going to be there, but for this type of work, we can do it from anywhere. EMS training, we get some positive feedback on all of the EMS training that we do. We're trying to get a little bit better handle on how many of these we run EMR and EMT classes. A lot of confusion about that because well over half of the EMR funding goes to teach EMT classes because there's a tremendous need for EMS personnel. We're trying to get a handle on retention rates and pass rates on those courses. We might EMS training, I talked a little bit about that, but I actually hope to engage the same individuals, but help us develop a hybrid EMT course that can be done a little bit easier. We've done a couple of pilots on that in the past that worked fairly well. Not where we want to be, and we continue to monitor our experiences. Any questions?
Good report, Courtney, a lot going on. Any questions for Courtney? Thank you, Courtney.
Dr.
And
Ashley,
who was that? Go ahead.
this is Tracy. I'd like to make a comment. I think Courtney's outlined a lot of things that the EMS Advisory Committee and other groups related to them are doing and trying to get a better idea of what is the state of, the number of EMTs and their retention. They've done a lot of good reporting about that in assessment. But what I'm seeing from the hospital side, like I'm working on a time to definitive care report for Gina through our GCT EPI committee. And part of what I'm seeing also is maybe just the coordination of when that call is made to get EMS into the hospital. There seems a big gap of time there, in the few transfers in that I've looked at. So that might be an opportunity on our side. I think it's going to be really hard. I think it's going to be like some of our PI stuff in the hospital. It's so multifactorial that we're just going to have a lot of moving parts and everybody's going to have something that we have to do to improve it or improve the time to care. But I see where we could coordinate our communications better, either from the transferring hospital and or from the receiving hospital.
Tracy, that is a great point. We're a hospital-based ambulance company. And we have those same communication problems. Sometimes they'll have a trauma that the EMS is out on another call, they don't know it's there. And when they get it all set and make all the arrangements, then they call EMS. Well, now EMS may have to call in extra people to do this or that. And it is extraordinarily important, and we probably need to put that as part of March Paul's curriculum, that when they see that patient and know that it's going out, that EMS is notified there, so their ramp up time can start as quickly as possible. That's a good one. Good one.
Tracy, another interesting item to your particular survey that you're doing, I would be interested to find out the time difference between the first call, because some of these hospitals were actually having to go through multiple agencies just to locate one. So I would be interested to find out first call to the call that you've got that an EMS agency actually responds.
I don't know if we, like for the registry part of it, we just know, I know whoever the transferring agency is, we've got the dispatch time and then, scene. So you're 4 times, scene, then leave scene, arrive at your next destination. So we've got that for the scene and then the transfer. But that's a very good point, I think. And that's something we run into a lot with transfers, that you've had to call a lot of agencies. I think Kelly's even helped us on a couple of PI cases we had several years ago where they had to go through 3 or 4 agencies before they even found somebody that had availability. Sometimes it all comes down to timing and the day of the week. And when you've got a lot of calls out, there's just not that much to go around. But that kind of goes back to what the EMS Advisory Council and some of their work groups and other groups associated with that are looking at, what is the retention for the EMTs and then availability and, it's just a really complex view, but I think that is something that would be worth looking into. To look for availability, because that is definitely a big problem.
David, would the NHTSA evaluation or visit, is that part of it? Availability of inter-hospital transportation from EMS, is that part of the NHTSA visit, or is it mostly just ground to first hospital and then regulatory issues regarding ambulances and licenses?
Well, so it includes a whole section on systems of care, so trauma, stroke, cardiac, all of that, which that would be part of that.
Okay.
So that's what we've instructed them because we've already had our pre-visit, not a visit, but a conversation. And what we've instructed them is that we really want to focus on our systems of care, which of course, like I said, that would be part of it, is the whole getting back and forth from, first hospital to the definitive care.
Because that affects, cardiac, stroke, and also trauma. So it affects a lot of things.
All right, good discussion. Thank you, Tracy. All right, let's move into the Georgia Committee for Trauma Excellence report from Jesse.
All right, can the folks on the call hear me okay from here?
You might have to move up a little closer.
You might have to, but I don't think the owl can pick you up.
Yeah, I think the requirement is you got to be 3 feet from Dennis. I
Oh,
think that's
gosh.
the requirement.
How about here?
That's good.
That's right.
All right,
Jesse's
as
so
you-
shy and retiring.
That's right, I'm very shy. So as you can tell from your report, it is a pretty lengthy report. I'll try to summarize it. But all the great work that's done through GCTE, we certainly want to share with you guys. So I'm just going to break it down by subcommittee. First, our pediatric subcommittee, they continue to work on several things, including some gun violence initiatives and the shock index specific to pediatrics. But I think most of their work right now is going into a pediatric readiness presentation. As most of us know, there's some additional requirements coming out with the new resources for optimal care document. So we do need to prepare as a state for some of the new requirements for pediatrics. And so that group's kind of taking lead on that. I was told they're going to be doing a presentation during the summer meeting on pediatric readiness, and that they will also be distributing a pediatric readiness package at that time. So looking forward to that. Moving to our registry subcommittee, to tag right on to the conversation about time to definitive care and the reports that Gina and Tracy and all the teams are working on. The registry group is working on that report and in hopes to submit it to the different centers and to identify some themes in where our real gaps are. And again, I think as we just discussed, data is one big part of it. So we can't really fix what we hypothesize are the problems until we really have the data to support it. So they are working on that. Additionally, their group is doing some discussion and presentations around the new 2022 ACS standards, which will require an increase in our trauma registry staff. So there are going to need to be some discussions, potential increased resources to our trauma centers to cover those additional costs. And then moving on to our education subcommittee, they are also working on transfer to definitive care. And if you guys remember a few meetings ago, I talked about how our GCTE is really trying to work on some strategic high-level goals that feed into the work that the entire state trauma system is doing. So that's why several of their groups are focusing around time to definitive care and really kind of the component that each of them can respectively own. So the education committee is working on a basically like a PowerPoint that they can share with our non-trauma centers and our lower level trauma centers to sort of, it's almost like a brief RTTDC in a way, just to share, what injuries are a little more need rapid transfer versus those that may not. So they're working on that. They're also doing a presentation for acute kidney injury because we know as a state we're low performer in that hospital event based on our TQIP feedback. And then they were also given the challenge to sort of reallocate some money. I think Liz and the team, there was like $11,000 left in a budget that needed to be spent, and we knew that there were some needs from an education standpoint. So with that funding, the education committee did some surveying and sort of really focused on what our top needs were. So they are funding an ATCN course at Grady, which will happen in June. That's going to get 24 participants. I'm sorry, maybe 40 participants. A little confused on what I'm reading there, but working really great to get that going. They also have funding for a TNCC provider course, which they're going to be doing at Phoebe Putney, which is really good. Yeah. As you all know, Phoebe Putney's on their journey to become a designated or verified trauma center. And so we know that we need TNCC instructors so that we can continue to grow our nurses across the state. So that's really, I think, very important. Also another TNCC instructor course at Piedmont Henry. And also they were able to purchase the new STN Trauma e-Library, which is a great resource for nurse education. And that is open to anybody in the state. So really great work by that committee. And then also our injury prevention and outreach committee. As you guys know, many of you are probably on some of Crystal Smith's emails. They are one busy group. And so especially this month, as we've talked about, it's, mental health, trauma, injury prevention, all those months, but they are really doing a lot to get the kind of the trauma calls and everything out there. And so they've done a lot of Stop the Bleed training during this month. They're also doing several things around preventing trauma, the Road Ahead, which is a traffic injury prevention task force, and some work that goes into that. Also looking at a prevent trauma child abuse program, and they continue to do the bingo size program, which has been very successful for injury prevention for our geriatric fall population. And then last but not least, our PI subcommittee is also working on that same goal of time to definitive care. And they're actually looking at it from a little bit of a different angle, looking at some specific cases and trying to discuss those cases amongst their group and find trends in things that might be barriers to getting the patients out, like what we just talked about is it the transport service, is it time to decision? So they're trying to really nail down some of those things that we might can work on. That's all for our group. We do meet this afternoon, so I'm looking forward to a hybrid meeting. We'll hopefully see some of the folks. Any questions for me?
Yes, it's not a question. I guess it's kind of a comment, because we talked about the before you. On those days, talked a little bit about teletrauma, and that's been something that's bad. trauma patient out, they do have a little bit better mechanism for teletrauma, so they could send them with a stroke all the time. So that they would actually do better care while we're waiting to get to it. So that would be helpful. I don't know if that falls on y'all's recommendations or not.
I mean, I don't know that that would necessarily fall through GCTE, but I know some of us, like, you know, I know with my own health system, we have some abilities through technology that I think in the near future, we may can do a little bit more of that, but I don't know that we've yet approached that from a state level and what our opportunities there are.
She's giving me that look. I don't know if that. I seen her give it.
I have to be very careful. I was just gonna.
I think it's just complex in that if the patient's still at the other facility and they're under the direction of the trauma facility, you know, where does the kind of liability lie?
For what, say that again?
The issue that we have talked about at level 3 was about the ability to consult with a level 1 center or
Oh,
level 2
yeah,
center.
yeah.
But sometimes we may not need to transfer.
Yeah.
Right.
You know, sometimes the mechanism of injury, we reviewed one this week, our trauma committee, mechanism of injury is terrible. I was up walking around with that.
Yeah.
Send it to the trauma. center.
Yeah, as a level 1 center, I don't even know what the legal ramifications are. If we get asked all the time, hey, listen, I got this patient, you know, should I transfer him or should I not? And my answer always is transfer him because I can't examine that patient, right?
Right.
Even if I don't think he needs to be transported, I can't say that because I don't know if they missed an injury or not, right? So I'm very reluctant. I will tell them what I think for sure. But from a transfer standpoint, my answer is always just transfer. But if they say, hey, listen, it's got a pneumothorax, should I put a chest tube in? I'm going to always err on yes, you know, but am I now legally responsible for the patient? I have no idea.
Right.
So I think there's a lot of application. We did it years ago and it was just way ahead of its time, like potential for telemedicine. We've started a partnership with Emmanuel looking at ED telemedicine. There's already critical care telemedicine. We've got a critical care telemedicine, you know, and they give, so the telemedicine physicians give remote, you know, they manage patients from a remote location. There might be some applicability now coming back around to lower acuity patients that could be evaluated through telemedicine. You know, to keep them in there. It keeps the funding in the rural hospital, keeps the patients closer to the family. There's lots of positives to it. You know, we do telestroke, although they transfer the patient, but you know, some of the minor things, and then, you know, we can certainly look into it. I think it would be written in your agreement as to what would be responsive, but there's a handful of big pushers, right, of telemedicine at our facility who's really trying to do that. I don't know, you know, now in your new role, if you've had much exposure or participation in the ED telemedicine telecritical care project.
I know that Damien and Dr. Lyons and some of them that this week, yesterday, we discussed that in our trauma committee. So I think that would be a great, if we make that work. The thing about stroke is you got CT, so that's something really definitive there.
Yeah.
Trauma is more, she's more hands-on.
Yeah.
And they can color skin and what they sound like and how to do that. There's a lot.
I know Dr. Todd's on the line, and I believe this came up and the GQuip call the other day, and certainly in times of austere care during COVID and surge, there was not the need to take up trauma beds with grandmoms who were only going to decelerate care. But Dr. Todd, do you want to share with how that came up?
Yeah, Liz, thank you. I just raised my hand, so perfect timing. No, exactly. We discussed that on the advisory committee the other day for GQuip about what that could possibly look like and how that could be impactful. You know, and speaking with threes and fours, that was something kind of came up from the standpoint of keeping the patients locally, but also some of these patients don't get transferred, then tap the one ambulance for that region for a period of time. And so, how do we keep those patients back home when they don't need to come over? So I think it's definitely something we should look into, and what that could look like. having talked to Lakshmi, who's the Grady EMS medical director, they're already looking into that from certain elements from, you know, an EMS perspective. So I think it's something we definitely would love to look into further and what that could look like with our other centers.
Yeah, plus cost prohibitive now too, you know, you had to have that fancy stuff and you had to connect and it was dedicated, you know, a lot of it's off the shelf. Telemedicine. It's a lot
Right.
easier than it was back when we tried to do it.
Oh, sure, yeah, absolutely, especially with the telestroke and you know, all the, those issues. Some of that difficulties are bringing them down.
Right, right.
Thank you.
All right, Dr. Dunn, in absence of our illustrious chair, do you want to send us into the break for?
No, we got one more, oh, you want to go to break before we talk about, finish up the two committee reports?
We're-
Yeah, so is mine is, both of them, the last two I think are super.
Sure,
quick. So why don't we
okay.
go ahead
Yeah.
and go with Michelle really quick?
Yeah, absolutely. So we had a great meeting at Barnsley in March. We have since had a smaller work group committee, and we did have the larger group committee the end of April. And so we do have work group chairs. Our three work groups are finance, saturation, diversion, and education. And we have chairs for each of those, for each of the committees. We will be meeting. I sent them the list. We had, thank you, Gabby, for sending out the doodle poll to folks. So we've had about 12 administrators sign up within the three subcommittees or work groups. I'm sorry, I keep saying subcommittees and work groups. Only 2 for finance, a bunch in saturation, diversion, and a few for education. So reality, I'm not going to send the list out again because we get too many folks in there and people are just participating to participate. They're not actually going to add value. So we'll start with that. The plan is for them to have at least one committee meeting before our meeting, our full meeting in July, which is going to be virtual. Originally, we were going to do it August in person, but trying to get administrators away from their hospital twice a year is just going to be too difficult. So we're trying to be sensitive to that. What we will do in August is all the work group chairs said that they would be available. And so we'll all be there. So the 5 of us will have our own like little strategy session for the trauma subcommittee or admin subcommittee. So I think we're definitely making some progress. And I think the last thing is, we talked about the work groups, is the GCC status for trauma. So I've sent the screenshots to both Liz and Regina, provide some feedback for that. So we will need to finalize what our request is to send to DPH for them to approve. At the same time, we will need to understand education, rollout, sustainability. So it's not something we can just change, like there's going to have to be a plan around that. So I would like for the saturation diversion group to give feedback on that, since they're the ones that are using it. But I do think we also, from the work group chairs, so Katrina Kiefer, who's the finance, but she's transitioning. I've asked her to give me another person. And then Francis from Wellstar, and Amy from Effingham, and then Damien is doing the education from Emmanuel. So I think we got a good cross of the whole state to give everybody's perspective versus just the cities. So that's it.
Great. All right, we'll move into the last committee report is mine, the trauma system performance. And I am super excited from what I'm hearing from the group here about the lack of engagement and the enthusiasm for the Trauma Commission's priority of, time to definitive care. We've got the MS subcommittee working on various issues regarding that. We've got the I can never say that, the GCTE committee working on the registry part of that, because that's huge from our pulling our data. Office of AMSD has been instrumental in helping us pull data and analyze it. We had an initial data pull several months ago that we were able to analyze. Unfortunately, that was only a very, very small percentage of the overall data pool, so it's very difficult to make definitive decisions on that. It was like, I don't know, less than 10% of the overall data that we were able to access. But even with that, as we showed last commission meeting, there were some issues or trends that are starting to develop, one of which is transfer from point A to point B. And so, with the help of all the other subcommittees, I think we're going to actually be able to crack that nut. The big issue, the big hang up we have right now is the conversion over to image trend at the state office. So we've been unable to analyze any further data since our last commission meeting. We've got to wait for that transition to occur. And David, do you have any idea when that will be complete?
I'm hoping that it will be completed by the end of June, because the next download is due at the end of June for the data through the end of March.
Yep.
And we're working closely with the pilot, the one pilot, to make sure the files are right. And then if they are correct, then the remaining pilot centers will receive the files to test. And then if all goes well with them, all the centers will do it.
And how long does it take to convert over? Do you have any idea? Say that all the pilots are good to go. How long would it be to convert over?
It's just a matter of the facility installing the files and getting their IT department to help them.
That could take months.
IT department, those are the dirty, two of the dirtiest
You know, you
letters.
got, I don't know how many trauma centers across the state that are shipping you data. But if we have to wait on each IT department to try to figure that out, and that's gonna be a while.
How many years worth of data are you migrating older data over, or are they sending you older files, or how's that working?
Well, they have the ability to enter a date range, and so what we're working on is primarily the July 1st, 2021 data through what will be the ending date, March 31st of 2022 data, because that's the chunk that we don't have. We have the data from June 30th, 2021 back in our legacy CSV files. So that we can import.
So I guess I'm a little bit confused. So most, if not all, the centers in Georgia are on ESO or DI, and you guys are on image trend. And so there's the conversion from DI to or ESO to image trend. Image trend is the issue we're dealing with, correct?
Well, we provided ESO with the schema files, and there were some issues with the files that were sent to the pilot center.
I mean, as far as mapping from ESO to image trend, or?
No, it had to do with code and having how the schema was built and how the data was being transferred from ESO to, or from V5 to the image trend system. So we've identified in the code what the issues are, and we've told ESO what they need fixed in the files. And then, so the holdup now is on the ESO side.
Yeah, I
So
think
we're
it might
waiting
be.
for them to send that file back to the pilot, test it again, test it with the remaining pilots, and then send it out to the other centers. And it only takes maybe 15 minutes to do the download. What we're, the holdup right now is getting past that first pilot.
Sure. And is the expectation that the individual centers will convert their data from ESO to image trend, or is that going to be done at the state office?
Well, with the transfer file, the schema file that they will have, their system will do the conversion, package up the data, just like it did before when they were sending the data to the V5 central site. And their systems will package up the data and give them a download file. And they will log into the image trend system and upload that transfer file.
Wouldn't it be more efficient to have the state office be able to do that? That way the state office can deal with their IT issues rather than have 28 or 30 centers have to try to figure out how to convert their or upload their ESO files to image trend?
We've already provided the data files that the V5 needs to the vendor. And you have to remember, we don't have access to the individual hospital's databases.
No, but we have to send our data to you guys, and so you would have access to that.
Right, so that's the way to send it to us, is to upload it to the image trend system.
Yeah. Okay, that's okay. That may be a lot longer than June before we can get data to come out of image trend. That's my concern.
But it's whether they email us the file, which they can't do, right, because it's probably too big, or just upload it, it's
I'm just concerned
uploading.
about the having to rely on each individual center to figure out the uploading from ESO to image trend. And there's good, I mean, I can't even turn my computer on after an Epic upgrade. So, when you do two different centers and expect data to map over or to upload, there's going to be issues. And I'm just concerned that we're not gonna have any data to analyze for several months.
I also think you're right. I think another barrier is gonna be we all live in cyber hell, as I'm sure you all have to do your cybersecurity training and so forth. So just to get a simple report out of finance right now for me, I was just telling Michelle, for the finance committee, you have to submit a request, it has to go to a committee, and the committee has to have me come present before the committee, and the committee votes, and then it's months before you get it. So I think IT security is gonna be an issue with a new interface where we're uploading data and then requesting security. It's probably gonna be way past, I mean, you may have the ability in March, but I don't think we're gonna be able to upload data. You were feeling the same way, probably for quite, and probably yours, larger centers,
Yeah.
quite some time
So
before we're even able to
we've gone
send
through a
data.
lot of this when we have EMS agencies and they choose their own software vendor. They still have to send it to us. It's just part of the
I get
regulatory
that.
requirements.
That's not what I'm talking about. I get, and I understand the interface piece. I don't think that's gonna be as big of an issue. I think what's gonna be an issue is IT and IT security.
Yeah.
And
I would agree.
IT's requirement to, because I have that issue even with updates to ESO. I mean, it's like an act of Congress to get somebody from IT to assist in the
Right.
change.
And if
It's
you
not like,
multiply that by 36.
it's just getting worse and worse.
Yeah, it's gonna be challenging.
Even if I log in at my desktop, I still have to do dual factor authentication
Oh, yeah.
in the building at my desk.
Yeah, I know.
So
Yeah, I get, yeah.
Yeah.
So.
access to data is gonna become harder and harder and harder, I think.
So I think
We'll have to
we're,
work through it.
we're on hold for that until, I guess, all the centers have uploaded their data to Everstrand. And then you guys have the ability to run reports from Everstrand. You guys have the report writing capability at the state, correct? From Everstrand, it's similar to ESO.
Better.
Yeah, okay, great. And then we're still awaiting, I guess, David, where do we stand with the pilot project in Region 10 for the armbands?
We're still working on getting that together. We've met with the EMS EPCR vendors to let them know where that number needs to be entered into the trip report or scanned into the trip report. So we've been working with the EMS vendors. We're now working with hospitals, and primarily it looks like we're gonna narrow it down to a couple of hospitals to work with them to see how that can be entered into their system, as well as we're working with the governor's office of highway safety and some law enforcement in the pilot region to determine, making sure where it's gonna go in their reports, and then developing the training with our conversations with them for each of the entities, law enforcement, hospital, EMS, so we can start training them on what we're doing, why we're doing it, and how it will fit in there. So we're still in the process of putting it all together.
So what do you expect as a go live date for the pilot in Region 10?
I don't have one for you. Because it's gonna depend on our partners, the hospitals, the law enforcement, the EMS, on getting their systems ready and educating them and getting them ready before we'll have a better picture of a go live date.
How many hospitals are there in Region 10?
I don't know specifically, but it looks like with the information we have now, we're gonna need to narrow it down to not all the hospitals in Region 10, maybe a few select ones in Region 10, as well as the designated 1s and 2s on the outside border of 10 that those hospitals normally send their patients to. Because if we're gonna try to get every hospital on board, and as you know, every hospital uses a different electronic reporting system. And so, then you have to work on this. It may be easier for us to do this pilot by starting with select hospitals.
What do you mean by electronic reporting system? You mean
Their
electronic
medical
medical record
record
or the
system.
electronic
Their
record?
electronic medical record system. Sorry, we call them different things, but they do the same thing for the entities. So with having to work with every hospital in 10 or Region 10 and the hospitals, we've looked at the 1s and 2s that are on the outside of 10s, that those patients are primarily transferred to, because they need to be included in education to know what that number is and to put it in their system. So I think we're gonna narrow down the hospitals so that we can at least get the pilot started and get some preliminary data. If we try to do it with all the hospitals, I think it's gonna take us longer than we want, if that
And-
makes sense.
There's
Right,
only
yeah,
a
it does. And then,
handful.
but after the
Region
pilot,
10.
we're only allowed to use the armbands on motor vehicle passes. Is that correct?
For our funding stream, yes.
For the current armbands we have today that were purchased through the governor's office.
We can use them on anybody.
No,
No,
those, we
Those
can
are only
only
on
use
car
those car crashes.
Oh, I thought the pilot was able to be used on anybody and then in future with armband.
nope.
So that narrows even the scope of what we
It
can
does,
do.
it does. with
So
the-
this may not be, meet
Well,
our ability to answer our question from ditch to door. That would really-
maybe not, but if we see that this works on a small subset of patients, that's got a focused, look at it. If it works on them, then we broaden out on others once we find funding for that.
Right, but but the ability to do that from an education standpoint sounds like it's gonna take months, if not years. Because if you're having to educate all the regional fire departments, all the regional police departments, all the small hospitals, all the.
That's
But
gonna
that's why, well, it won't take years, but that's why we're saying we need to narrow it more down. So that we don't have all of those, which won't take years, but it'll take longer than we.
Just for the pilot, but if we want to expand it, it's gonna take a while, right? The longer, right?
Hey, Dr. Dunn,
Yes, ma'am.
this is Tracy. I just want to let you know, and Kelly might not be aware of this. I talked to Casey last week because she was asking for some suggestions about, how to streamline the process. And so Kelly, I didn't know if you've had a chance to talk to her, but we talked about maybe, like you've talked about, getting it down to one hospital, how to work with that hospital, because a lot of it's going to have to go through their, like their IT and their corporate compliance stuff. So she took a lot of notes. We had like an hour-long conversation. And I told her if she started there, then she could go out. Now, that doesn't answer your question of how long that will go, but I think she was seemed like she was leaning that way, like Kelly's talking about. And then you could kind of just talk about that, that one facility starting off with that. And then, the EMS or law enforcement in that area. Now, as far as transferring to another hospital, we didn't get that far, but at least we started with, where to start in that one hospital to get the people educated, find a place in the EMR to put it, how to scan it. Again, it depends on the EMR and where you put that stuff, but I think it was a good conversation. I'm just not sure, how or where she's going to follow up. So maybe we need to get something from her to see what she's got going.
Tracy, I have talked to Cassie.
Okay.
Tracy,
Okay.
yes, I have talked to Cassie, and that's where this came from, that maybe we don't need to do every hospital in Region 10 because everybody uses different EMRs. And it's not as easy, it sounds like, for hospitals to add fields to their EMR or use fields in their EMR as it is for EMS. There's our
Correct.
EMS is a national data set. So whereas the ambulance service at your agency, Dr. Ashley, uses the same data set that the ambulance service at Courtney or at Vic's agency uses. So it's going to be easier with the EMS to do that. It's going to be a little bit more difficult with the hospitals because of that. And so that's where we're working on that. Like I said, we are narrowing it down. And Tracy, I don't think Cassie followed back up with you. As I told Cassie, I don't want to leave out the level 1 or 2 that this hospital that we, or the hospitals that we choose
Right, you have to
have
include
their
those
normal,
hospitals.
because then we're gonna miss
Yeah, you have to.
the in definitive care.
Right.
So
And in that respect, I told her if she thought about, you've got like 2 or 3 big hospital systems in Georgia, and maybe start at a system thing, because within a system, you might have the levels you need. And so that would kind of help push that forward a little bit quicker. You know, just because I have Epic and Grady has Epic, that doesn't mean we're the same EMR. It's just the same platform. But the way they set it up and we set it up are two different things. But as Regina mentioned, when you request something for finance and it has to go through committees and people have to, you know, genuflect over it and pray over it, you know, IT is that bad or worse. So, but if you can get it done in a system, it makes it easier after the first hospital to get subsequent hospitals going.
Just to throw it out though, the whole point, and why don't we go with the question over here real quick?
So there's only one level 2 hospital in Region 10, and it's us.
Okay,
So
great.
that narrows it down. And the hospital that transfers us probably some of the most is Piedmont Walton, which is a part of our system and is also on Epic. We're both on Epic, but I can tell you from our hospital standpoint, you're gridlocked from anything with EMR because we've recently taken on 4 new entities and they are all moving over to Epic now. They're all in the process. So we will be gridlocked from anything for quite some time.
Right, so would it be possible then, I mean, this armband has a number on it, correct? So can't we just handwrite the number into the doctor's progress note or the nurse's progress note so we can track that number? Obviously, it'd be infinitely easier if we could just scan it and it shows up in the EMR in a field that we can run a report on. That would be infinitely easier, but at least we could, for the pilot, we could do, we'll have to do hand abstraction, but.
I guess that's possibly some way we can go, but then how do we get that number off the doctor's progress report so that we can start linking up all these?
As long as the trauma
records?
registrar can see that, and then
Yeah.
when they're entering the trauma registry record, they can just type that number in, because there is a field in the trauma registry.
Right, and that's where all this number would have to go anyway, so it's
Well,
gonna
our
have to
trauma
be.
registrars look at the H&Ps.
Right.
History and physical, our note when they come in, because that's where all the stuff, they have to read that note.
Right.
So that's easy for us as trauma directors to mandate pretty easily, like tell the team at a certain spot in the note, we even put it the front and end. I mean, we could even make it easy for the registrars to find.
Right.
But
not
we could do
the-
that and have that number there, and then the registrars could put it in the registry if that helps you all. I mean, we could make that happen pretty easily, regardless of what EMR you're on. Right, that part's easy.
But going back to your system, if we did it that way, would y'all be able to do that without corporate or administration giving you the approval to put those numbers or utilize those numbers? Or I'm just asking. To put the numbers in, no, you're talking about typing a note. I mean,
Yeah.
That's not.
That'd be easy to do.
That's just a place.
We don't need any committee,
Putting
we
a
don't need
field
any
in
approval,
Epic.
we don't need anything.
That's everybody and their brother. But what, just, so that's where we're at on the armband. We're working on it. We are limited to who we can use it on. But at the same time, I think that's a positive if we focus on one subset and see if it works. Then we branch out instead of going all in and seeing it doesn't work.
Yep, I agree, I agree.
But just while we have so many hospital representatives in here that are used to using EMRs, do you in your EMRs already have a place to put a triage tag number?
No, at least not, I don't know.
Yeah, that's, because that was my thought is, I thought there was already a field in the EMRs for the triage tag number.
If there's not a field, do you?
You know,
currently
there's
type
gotta
that
be
into the notes?
something, yeah, there's gotta be something, because when we do drills, that's how we register people.
Yeah.
So there's, I just don't know, but there's, because they don't come in, they're not registered by name, they come in with their tag and they're tracked by their tag number.
That's you're talking medical record number or a account number,
It's
correct?
probably
pre-done,
it is. They're pre-disaster.
Well, the pre-package with the
Yeah, for
registration
disaster
number, but
packs,
is there
yes, right.
somewhere we put the triage tag number in? No?
We don't.
No, we don't.
Okay, that was a thought, because that's one way in a disaster situation that you can connect. This patient came in from EMS, and these two records match because of the triage tag number.
And usually most places stay on paper. If it's really for pulling
That's
disaster packs, you're
Okay.
not using your.
Right.
It's just a question. Okay.
All right, so more to follow on the data subcommittee, and hopefully we'll have some data to present in the August meeting. But we're kind of on hold right now.
Okay, thank you, Jim. So why don't we take a 10-minute break here? And
Enjoy some
we'll be back.
donuts.
And for those that are online, waiting for the reports, we'll reconvene. That's, I have 11:12. So let's reconvene at 11:25. Okay, we'll go ahead and get started here. Back. Looks like first up, Cheryl from the Georgia Trauma Foundation.
If I project, is it all okay? I know that here.
I think you're gonna have to come up, yeah.
They can't hear you online as well, and we'd love to see your beautiful face.
You're right. So for today's report, there are a couple of things that we wanted to share with you all. You know, earlier when Liz recognized Jessie for her award at STN, she mentioned that Georgia has a lot of leaders who are being recognized nationally. And that's one of the things the foundation wants to do, is we want to be able to lead and be recognized nationally. So in order for us to do that, we've got to first start by raising, of course, as you all know, millions of dollars to support the state's trauma system. So to get us started off on the right foot, we've entered into partnership with Alexander Haas. They are one of the top fundraising consulting firms in the nation. And if you're not familiar with them, for the past 3 decades or so, they've worked with thousands of nonprofits to get them where they need to be financially. So in our first engagement with them, what they're going to do is help us put resources in place so that we can reach the levels of success that we need in order to advance the state's trauma system. Another thing that's going to help us in the area of fundraising is board expansion. And we have successfully onboarded one director, and under the advisement of Alexander Haas, we won't be adding any more until we put together a recruitment strategy that is going to be specifically based on what our fundraising needs are. And you may ask why. It's not because we are necessarily looking for board members that really have deep, deep, deep pockets, but we are looking to strategically put together a board of directors who can help us singularly focus on raising lots and lots of money. So they may have lots of money themselves. They may have connections that we need, but whatever it is that we do as far as adding members to the board of directors, it is going to be strategic going forward. So this is actually an area in which at some point we may ask for the commissioner's input and the input from some of you other folks in here who are part of the trauma system. And that's just to provide us with maybe some names of people who might make good board members for the foundation so that we can help advance, again, the state's trauma system. You will also recall that historically, the foundation's activities have been centered around education. We have a project that's in the works now that is going to be a tremendous help to the trauma community, and it will help us provide support in really an unprecedented way. We've partnered with the State Office of Rural Health, and what we're doing is we are spearheading a continuing education database project. And upon completion, the database is going to actually serve as a one-stop shop to identify course faculty for state and nationally approved continuing education programs. So what this means is that there's no more calling around to find out who can teach a course or wondering if a person is credentialed. All of the information is going to be available soon. It'll be online, scheduled to come online by the end of this calendar year. Any questions? Dr. Bleacher, did you want to add something?
That was well done, Cheryl. But I do think that it underscores the commitment to adding a level of professionalism to the foundation in reaching our goals by engaging Alexander Haas and using their expertise to leverage our ability to get to where we need to be.
And they have a history of working with all different types of nonprofits. As far as what the nonprofit focuses on, they have lots of experience helping foundations, helping healthcare organizations, and helping organizations of different sizes. So of course we are small now, but we want to grow, and it looks like that we may be able to work with them, not just through this initial engagement but for some other things we may have on the books going forward.
Yeah, I'm very excited to hear the direction of the Trauma Foundation. I think the direction you're headed in right now is kind of what we've always envisioned the Trauma Foundation to be. That's the reason I think why it was stood up in the first place. So I'm very, very excited with where you guys are going. Just to help manage my own expectations. Is it reasonable to assume that once you guys get your feet on the ground and you get moving, that you will be a self-sustaining committee, if you will, and that you will be putting money into the trauma center and into the trauma foundation or the trauma system, rather than having us, the trauma commission, having to fund you to get.
So
Or do you see it as required
by statute,
baseline funding always to occur from us?
by statute, the commission will always fund our operational costs. That is by the law. But to your point, we expect that we will be able to provide to the trauma system, the commission, meaningful amounts of resources for, say, for example, we had allocated $1 million worth of research grants not too long ago. We allocated $280,000 worth of injury prevention grants. We would like to see that be something that we could on a very regular basis.
Right.
You know, $1 million a year of research grants, $300,000, $400,000 worth of injury prevention grants every year, that kind of thing would make it impactful.
Bringing that additional money from outside? Outside, not because the commission funded those research grants.
Right.
The foundation helped execute those.
I think the intention of the legislature in creating this foundation in conjunction with the commission was to provide a substantial alternative revenue source.
Right. I would agree.
Than just state dollars.
I would agree.
So that's what the intention is.
And in some ways, I don't really know how I feel about this, but in some ways, it's better if your operating costs are not, people are more likely to donate money if they know 100% of that money is going to the trauma system rather than to your own operating costs.
Exactly.
So, yeah.
It's a great ROI for the commission.
That's right, yes.
Right, at least that's our intention.
Yeah.
It really is.
Great work.
And in reference to what you were talking about as far as managing expectations, I do want to do that by saying that while it is great for us to partner with Alexander Haas, and we are certain that they will be able to help us, I would not say, look for us to add millions and millions of dollars into the trauma system next year, or maybe even the year after that. What we're going to do is once we get our starting blocks into place, we'll take a look at everything and we'll see what it is that we're able to raise in that initial year, and then we'll build fundraising goals in from there. And we will keep you all in the loop as far as what that looks like.
Yeah, like I said, I'm very excited about the direction you guys are going in, because I don't think we've ever been this far along with the foundation. So this is great.
Okay, any more questions?
I'd just like to echo Dr. Dunn's comments. Phenomenal work, Cheryl. I thank you for really pulling things together and working so hard. And then Dr. Bleacher, the direction we're going, I think is a very positive direction. And talking about fundraising goals, that's huge. So thank you all for heading us in that right direction. And I think the intent of the legislature was to bring the private sector into this and provide funding into the system, which is what you all can go after. which if we cover the operational costs, then the return on investment would be huge and provide things that we struggle with to provide, that we have. Funds. So, and, I mean, it's very exciting. But great job. Okay. We'll move now into the Georgia Quality Improvement Program report. Dr. Todd and Gina Solomon. You up first, Gina?
I am up first. Dr. Todd's on and he'll be typing in, but I just wanted to do a brief summary of the report that is in your packet. So the work groups are continuing their work. AKI plans to do some additional data pull for their work. We did have Dr. Jesse Codner, our research resident, submitted a poster on our AKI physician practice survey to ACS Quality and Safety. And it was accepted, so we will have a presence there. I do want to briefly mention he will be leaving us in June, and I am so sad because he has been phenomenal with us. But we do have Dr. Eli Laver, who is supposed to be rolling on. So this research resident has been invaluable for this group. I could not imagine.
So we will have, we won't miss it, have a gap. We have a fellow coming
Yes,
in for
we do.
picking up.
Yes, that will start in July. So.
Where's that fellow from? Is that-
It's from Emory. We do hope in the future to build a process where we can open it up to other medical schools and residencies for people who might be interested in that. So we're hoping to use some of the stuff that Jesse has built because he got his MSCR during that time and build what that looks like.
Did Jesse find that year helpful? This past year, did your current fellow find this to be a beneficial year for him?
I absolutely
Oh,
believe
he's
so.
published quite a bit and presented quite a bit, so I think it's.
Yes.
Okay,
Really
good.
greatly, but he's raised the bar, really.
I asked him to provide a summary of the benefits, just because, again, if you guys are gonna maybe fund another position,
Yeah.
which is great, because they end up being the workhorse for the papers. and things
Sure,
like
yeah.
that.
So, yes, he's got several papers he's working on right now. Everything from the NISQIP side to the trauma side that he'll be finishing up, and has had multiple posters and publications and stuff with GQuip.
Yeah, I mean, I've done research fellowships before, and my golf game got a lot better, but I don't know if I was very productive. So.
Well, I can assure you, Jesse has been awfully productive and a huge help to this group, moving things forward. So that
Make sure he
TBI.
knows that we are very appreciative.
Yeah,
I think
please
it has
do.
been very successful.
Yes.
So from the commission, maybe we could, just want to make sure I don't see him online there, but I want to make sure he gets the word.
Right, we will. And I was hoping he would be able to join us at the summer meeting, but he'll be back on rotation. So he's not sure I'll be able to do that, but we're hoping Eli will be able to join us as the new, so we can introduce him. That's our goal. So TBI, we have accomplished pulling a larger data set, and we're going to work to do some analysis on that. Opioids is continuing to work on the multimodal guidelines, and we've also started a VAP guideline review work group to take the work that was done back in 2016, 2017. One of the things we identified at the winter meeting is we had a lot of what VAP guideline when we asked that question, who was utilizing it. So it was a great time to revisit those, make sure they're up to date, and reintroduce those. So we have a work group looking at those. The Benchmark platform and Data Central site. Luckily, we had some movement after this was typed, which is very exciting. So I do have some more information to share. Our contract with Arbormetrics has been signed off by the Georgia Technology Authority, and they have now received the first draft on it. So we were just waiting for Arbormetrics to provide feedback on that, and hopefully we can get the commercial contracts team and our Arbormetrics together and hatch that out fairly quickly and start the build process on that. So that's about 21 weeks. We also do have a scope of work and timeline from ESO for the central site. And that's a 90-day build. So that will be much quicker, which will be nice. And we have the first draft of that contract has been sent to the Georgia to GTA as well for their approval. So we hope that the lessons learned from Arbormetrics we applied to ESO, and we hope that process will move forward much
Did you
quicker.
say something like 21 weeks?
21 weeks for arborimetrics
Is that from now?
for, once we sign the contract.
And we hope to sign it in June.
I hope, yes, that we have both of them signed by the end of June, by the end of the quarter. So, so that would hopefully be a kickoff sometime in December. By the end of the year, we would have a platform.
And then we
Good things are worth the wait.
expect to see some data in the first quarter of 2023.
Hopefully so, yes. And we have, Michigan has graciously said that Arborimetrics can share any of the metrics that they have already built working with Arborimetrics. So that's a huge win, and I know we're going to talk about that at the summer meeting for that. So peer protection and data use policies, we are still continuing to work with the special counsel. We recently focused on whether GQuip is a covered entity when it comes to HIPAA. And after a lot of research and discussions, they have deemed that we are not a covered entity. Now, that doesn't mean that we don't have, you know, privacy and confidentiality and all that, but it does make it a little bit easier
Okay, okay.
to manage that, not being under the HIPAA umbrella.
Yeah, that's a good thing.
Yes.
Everybody knows. I'm very black and white, good or bad.
Yes, it's
That's
good.
on the
It's good.
side of it.
The GQuip Trauma Advisory Committee, they are meeting monthly. They are very helpful, very engaged. They had a lot of input on the summer meeting agenda, which is attached. It is in your packet from that. And we already have lots of things on our radar to work for the strategic goals for the plan coming out of GQuip and those items. So I think I'll turn it over to Dr. Todd now. I think he had a few comments of discussions that have come out of the advisory committee.
Okay, Dr. Todd, welcome to the meeting. Sorry, we're running a little behind, but thanks for hanging in there with us.
No worries, no worries. Happy to be here. Sorry I can't be there in person. I think just what Gina hit everything kind of on the head. You know, I mean, I think we have an exciting summer agenda coming up. So we're all looking forward to that. The last thing the other thing I would say is, you know, Jesse Codner, Jesse really, like you guys all said, has been phenomenal. Having worked with Eli clinically, I can only imagine he's going to continue to carry the bar that Jesse has been doing. So that's exciting from that perspective. The other thing I just want to talk about is as far as, and Gina, you can help me a little bit, but as far as just making sure from the registry perspective, we're all on I think it's the 5th generation or 5, so that it basically keeps us all concurrent. It'll make it easier from the GQuip data perspective and also from the overall, once we moved forward, arborimetrics, just standardizing that so that we're talking apples to apples and not apples to oranges. Gina, I don't know if I said that eloquently enough or if you could say it even more eloquently, but I think that's, the advisory committee felt pretty strongly that would be impactful and be necessary for us really to move forward at full speed, so.
Yes, is to, as we build the central site, you know, we've modeled a lot of what Michigan has done, and that access to raw data is innately important for the risk-adjusted benchmarking platform to be successful. So that's why we have moved forward with having a GQuip central site where we will have access to the trauma registry data from a performance improvement perspective. That's what we will be utilizing it for. So right now, the designated centers are on V5, and in discussions with the advisory committee, it's important that we do maintain that apples to apples, and we really would like the support of the commission to keep the centers on V5. We think it's important. That's one thing when we discussed, had a meeting with Dr. Himela, that he strongly suggested they've had a lot of issues when they have centers on different platforms. So the interoperability of the data that we're receiving to the central site is just crucial to our work. So, you know, we worked very hard many years ago to get on the same registry, and we think that staying there is going to be very impactful for GQuip. And so the advisory committee made the recommendation that they would like support of the commission to support centers to continue with V5.
And I think just recapping on that, I mean, I think that is one thing we heard loud and clear from MQuip, from the Michigan Collaborative, is that having centers on different platforms really does make it challenging overall when you really try to get to that real-time data, which is what the whole purpose of Arborimetrics is.
Well, I think
And that's
what
all.
you all- I think what you all are trying to do, Rob and Gina, is go try to catch up with Michigan and go to the next level for the data analysis, which is really asking even more sophisticated questions than we get from TQuick, which we can actually, as all our stakeholders and centers say, we want to look at DVT rates, we want to look at, does heparin or Lovenox work better? I mean, that's already been answered, but just as an example, we're going to be able to drill down and really do some nice work. So I think to go to like the 4.0 performance improvement, I see where you're going with that. So that makes sense.
And we can move forward so much faster. I mean, just take the TBI work that we're doing, having to ask every single center, to build the reports, run the reports, and then send them, to me and then on to Jesse for analysis. And Dr. Benjamin is quite the workload to ask centers for that. Once we have the data, we can run all that data out of the central site. We can look for anomalies. We can do data validation and make sure that we are sending good data to Arborimetrics and build some data validation.
What we're really talking about is real-time data analysis on any question we think we could come up with, rather than every 6 months from TQuip. And this is going to be risk-adjusted benchmark data that we can get at a drop of a hat if we want it, right? Which is like Dennis said, it's TQuip 4.0 is what it really is.
And not only will we be GQuip be able to see, the cumulative on a state level, each center will also have access to their own Arborimetrics platform and be able to see how they're doing in comparison in real time once that data gets uploaded. So
Wow.
we're not waiting for TQuip reports twice a year.
Wow.
So then if the centers do an internal PI product, let's say you're having trouble with bed sores and you put in an action plan to have your patients do better in the ICU or whatever with bed sores, you can instantaneously, after you do your internal, maybe the other centers are not doing this, but you're doing it, you could sort of see how your rate went with other centers if your internal project made a difference. And give your hospital. So centers can actually work on their own as well as working with GQuip in statewide projects. I think that's pretty phenomenal.
Yeah, Dennis, I think that's probably the biggest value. I mean, the GQuip, I think what you just said is really the largest value. Currently, if we have an issue and we make some amendments or adjustments on how we practice, we really don't see the results of that for 6 months, really 12 months, quite frankly, with TQuip. The way it goes currently. So to be able to look at those changes and how they impact your patient's care and outcomes in a much more real-time fashion is going to be so much more impactful. It really is going to be amazing.
And then if your work groups, Rob, if they AKI or TBI or whatever it is, VAP, if all of us get together and we say we're going to institute a little guideline, and then we don't have to wait for the TQuip report, which is also going to have patients before the guideline went into effect, because it's a long period of reporting. So we could actually say we're going to check back in 6 months and see if our guideline made a difference with the centers that participated. So that would be the nice thing. Your committee could adapt more quickly.
Exactly.
You see, instead of waiting a year and a half to see if it worked.
Exactly.
That's phenomenal. That's phenomenal.
Exciting stuff.
No, so I see where you're going. That sounds good. Do you need anything from us, Gina or Rob, or just more information or?
Well, we can, they're all of them. I don't know about anybody in the pipeline, but everybody in the collaborative right now is on it. What I could do, I don't think you need to make a motion. I could add it to the contracts like we did ACS
For the pay for
verification.
performance, as far as,
Yeah.
because we're supporting the registry with funds.
And since we're technically considering this like a pilot, we can just say, at least for the next
3 years.
3 years,
Which is
yeah.
what
We
our
said we
Arborimetrics
wanted to
pilot
do like a postmortem on it, just to make sure, we want to, yeah.
Well, that's just fiscal responsibility
Yeah.
to do that. for sure.
Okay, so we'll add that language.
Okay, Dr. Todd, anything else?
No, sir. Thank you for the time.
Thank you. You're doing great work. We appreciate all the advisory committee there and their work.
Thank you,
Please
sir.
pass that along. Okay. Okay, next on the agenda, Office of EMS and Trauma. It says Renee. I think I see Renee online. Will she be going first? Okay. Renee, the floor is yours.
Thank you very much. Can you hear me okay?
Yes, loud and clear.
Okay, great. Well, I think several things have already been covered, and I'm sure David may have some other things to add, but Marie covered where we are with our data. The one thing that we are proud to announce, and you should have gotten a copy of our 2019 Georgia Trauma Registry Report. There was a lot of effort that went into this, and I especially want to thank Marie and Cassie and Dan Lynn. They really did, especially Marie and Dan Lynn, really put a lot of hard work into this, and all of our office had some part, but theirs was the strongest. So kudos to Marie and Dan Lynn on their part. Also, we're moving along with the redesignations that are getting cranked back up now that COVID has relaxed for the time being, I hope. So we're getting some of those back on schedule. What I do very proud to announce is that we have a first new level 4 in Region 4. West Georgia Medical Center in LaGrange is now a designated level 4 trauma center. So congratulations to West Georgia and LaGrange, and we're so happy for them. They're have a lot of dedicated people in that facility and are going to be working hard towards obtaining level 3 in the future, and have really put in the hard work that it took to get there. Very dedicated staff and great community support. So we're very proud to have them on board. Probably within the next month, there will be another in Region 4. So we're slowly building in that area where we had so many weaknesses in that. So it's been a great effort on those parts. And just moving forward, I think you have all the reports you need. David, was there anything else that you needed?
No, we don't have anything else that's not on our report on page 81.
Okay, any questions?
Thank you. I just want to say thank you for Renee for everybody, but since you're giving the report, thank you directly for the annual report. Really appreciate it. It looks very nice.
Is there, Renee, is there an expectation that we can get an annual report annually, or will Image Trend?
Yes.
Version of Image Trend back that up a couple years?
No, I think our goal is to have one of these every year. So they're already working on the 2020.
Oh, great. Okay, perfect. And are we gonna, is that gonna be based out of the ESO database or the Image Trend database? Or I guess I'm a little bit naive in asking that question.
I mean, it for the report, it really would not matter because we have the same data. So it would, we'd be reporting from the system.
Okay.
So it would be the same data.
Okay, great. Excellent. Thank you.
Thank you.
All right, thanks, Renee. David, any comments? Okay. Last but certainly not least, the famous Dr. Harvey. John, welcome for another presentation at the commission. Always
Thank you,
look forward
Dr.
to
Ashley.
it.
It's certainly an honor to be here today. Chairman Ashley, Vice Chairman Dunn, members of the commission. I'm John Harvey. This is Chip. Yes, I'm the guy with the dog. It's the way they remember me. And Fred Jones is with me today, who has prepared a rather extensive financial report that's contained within the package, which I'll proceed to read word for word. So I wanted to make a couple of comments today just about our activities that I think are highlights. And I thought it's interesting when we start talking about return on investment. when I work with MAG and their directors, when I worked as part of their executive committee, I was big on it. What are we doing with our money that turns out to be worthwhile? In the last 2 years, we have had 2 deployments at the request of the state that were rather large deployments. When I told you we put together an emergency response team of volunteer physicians in our state for a 2-day mission, because most doctors could tolerate that in their practice, that was the intent. And you generously gave us grant funds to prepare for that, to be ready. When COVID came into the state, we responded for 6 weeks with volunteer physicians that, with the funds, again, that have ranged when we first started from $75,000 up to about $170,000 in our grant funds. We provided the 6 weeks of support service with physicians that graded out based on FEMA salary equivalents in return on investment to the state of $1,020,000. That's pretty good return on investment. Within another 6 months, we moved with COVID into the vaccination phase and received another request. We provide a physician to the vaccination sites. And I said, sure, when do you want to start? And they said, tomorrow. For the next 6 weeks, we again covered every shift. We had 2 physicians a day that were at the Delta site. And that translated into another $750,000 worth of economic support for the state effort. Now, those are at the FEMA salary base rates, before you think I might be inflating this, which is somewhere between 40 and 60% of what we usually consider for civilian nurse or physician pay with our respondents. I was pretty proud of that when we put together the report, as well as the fact that we developed 2 new methods of response, because of course COVID was new and we didn't know exactly how to respond to the pandemic. And we wrote up some new protocols and some developments that were then looked at up through the state, and we utilized from the North Georgia line all the way down to the Florida border in our state. So we had fairly universal applicability and deployment within the state. In addition, we've continued to train and done some rather interesting training that we've shared with our other MRC local areas throughout the state whenever we go in to do training. We've done 2 rather large drills in the Warner Robins area in the last 2 years. One was in association also with our military counterparts, as well as the medical school there, in a large state type disaster drill. We've done another more recently this year with an active shooter, which we had participants that participated in the training group.
Can you elaborate on that one, John? The active shooter, give us a little more information.
That was an active shooter that the local area had requested for an active shooter at a school, at a state school. And it was done at the Central Georgia Tech. Thank you. So, and the students from there were the victims. The medical school that's near there helped provide training to the medical students that were there, as well as we had our MRC physicians that served as the faculty attendings and helped to coordinate the in-hospital and medical response to that event.
So
It incorporated the fire and emergency police and emergency medical services for the whole area.
So I'm sorry, so what did the MAG physicians do? Did those patients get transported from the school to a local hospital, or did they get?
They actually got field triaged with triage teams that were taught about the various field triage, like the COT. They then took them to the treatment areas that were there within the school. And they were outfitted like emergency rooms, or they had an operating theater. And the physicians there went through the treatment of those patients as they would have encountered it in the trauma hospital. That was done the year before with an even larger scale, because we had the military response unit from the 116th, and they had their physicians there and set up a mobile hospital as well as the hospital within the building. And we could actually play out what it was like to have a field hospital transfer into regional hospitals. So there was quite a bit of training that went on at multiple levels in that event. As you know, we're coming up on hurricane season. So we've also already worked with the Georgia Department of Health for their shelter support. We have worked with them in the past and actually developed a shelter support medical pack that we have 10, 12 of for our physicians if they go to support into the shelter operations, such as what we've had in the past when we've had to locate people in shelters. And we've worked with the Department of Public Health. They have a MOU that they've exercised with us to have a telemedicine and training program so that everybody's integrated on the state platform as to how to coordinate shelter management care in conjunction with the Department of Public Health. So we've integrated at a number of levels with the state to support services where they need physicians and come up with a shortfall, and we've developed a method to help provide that. So that pretty much summarizes our activities for the last couple of years. And I wanted to make a comment about some of the things I've heard in the meeting that you mentioned, one of which was how to get in front of legislators and let them know what we're doing with this. We have had the opportunity to do that. I was at the MAG Legislative Conference last week where we had about 30 of our legislators that were there. And we were able to make some presentations about both the MRC and recognize the support from the Trauma Commission to our legislators, as well as to honor one of our legislators, Senator Kay Kirkpatrick. As most of you know, she's been involved with the MRC with me since it began. She's been very active, and through the COVID response, she and I both contracted COVID as we developed that initial response from quarantine on daily telehealth platforms till we got the mobilization of everything we were doing. We recognized Dr. Kirkpatrick at that legislative conference in front of her peers with a recognition certificate and a coin for the work from the MRC that she has done. And she was able to talk a little bit about the meaning of what the MRC had been. I think when you mentioned what you can do to get in front of the legislators, it's even more demonstrative if you have a recognition like that, because it tells a story. In fact, I got up and told the story of what Kay and I did during the 6-week deployment of COVID, from the first phone call from the Adjutant General all the way up to the drawdown, where we then coalesced the results of what we've done in missions all across the state. So they were very interested in that. If you're going to talk to them at the state level about the effective super speeder funds, we at the Region 3 meeting last week discussed one of the little Stop the Bleed kits that we gave to a school was utilized by a teacher who took the training on a student that was somehow cut. I don't know, David, you remember where that was? We had a discussion, and it was just last week in the state that they feel like that credited the child salvage to get to the trauma center with a tourniquet. It was from the Stop the Bleed kits that we have done. It's a trauma commission and having put in all the public schools. So some of our efforts, we don't always hear about results, but when we do, we certainly ought to be able to utilize that in front of the state legislature.
The last thing I have is one of our board members was commenting that he had received an encounter with our police officers on the way to the meeting. And I was able to thank him for his contributions to the trauma system, which he was somewhat mollified that his funds were going to a good cause. I can tell you from the standpoint you were asking exactly how it occurs. Since my wife has also been a contributor, that was going to our place in Florida in Tifton. If you're worried about where, you might need to watch your speed. What they do is on your citation, if you reach that magic number of 20 miles over the speed limit, then they send you a second citation. And both this board member and my wife can give you the story of how you need to look for that second citation. Because if you miss that one, then they suspend your license, and getting it back becomes problematic, and it even increases the donation to the state coffers. But I'm not sure we get all of that into the trauma commission for the reinstatement of the license. But that's pretty much how the system works. And I think it's continuing to get us about $21 million a year. So certainly that's an advantage. I again want to thank the commission. I have tried to recognize the commission in its support whenever we have functions for training, as well as when we deploy. And I've given most of you the new little flyer in here. Instead of spend extensive funds, not out of the grant, but to get highly paid dignitaries, we get highly paid dignitaries, we just don't pay them. Like me, or Dr. Ashley, who's quoted in our brochure, or our adjutant general, who's made a comment that I think are all very effective. And when other physician volunteers read this, they say, I want to do that. So we get people to sign up, and then we go and respond. We had over 200 physicians at the height of COVID, with another 150 available that said they would make a way to respond if we needed. That was a pretty good response, going from a trained cadre of about 75 when we started, and it's increased our MRC ranks significantly. The last thing I have in the realm of recognition is that the recognition is very important, like for Dr. Kirkpatrick or our members, and I'm wearing some little ribbons here today for that purpose. The doctors and the volunteers that responded in the state response over those 2 periods were awarded service ribbons through the Department of Defense with the Humanitarian Service, the Georgia State Active Duty Service, and the Pandemic Response Service ribbon for those people that participated. And for those that were in a leadership position in coordinating and really put a lot of work in helping with the MRC response, the Department of Defense was very kind in awarding a state commendation medal to about how many members? I think about 25. In a very nice recognition award that General Cardin hosted out at Dobbins. And that was probably the best thank you. We gave certificates. I wrote a letter, and he wrote a personal letter that went to all of our members. But it was really a special ceremony, and the people cherished getting a service medal and a ribbon. His comment to that is, doesn't cost very much for the cloth or the medal in that little ribbon, but it goes a long way into recognition of what people have done. So I appreciate the continued support in our grant support. And grant support is very important, and we have tried to be faithful in utilizing it. We give you all the numbers, and I'm happy to answer any questions that you have about our report or what we've done with the funds. But Fred's got all the answers on those dollars and cents. And we would, I guess the last thing is when we come up to grant renewal, we would ask for, again, the continued support for readiness. It's hard to be ready for what you don't know will be the next state emergency. I'd love to say we could plan, but when COVID came out, last pandemic I planned for was bird flu. That was 10 years ago. We had to pull out a lot of new views about what to do with this little bat fever that we got take over to give us problems. So it's hard to predict what to do with training funds or planned funds, but I think we had a universal approach and stayed with the readiness attitude of being able to respond to whatever the problem was. So with that, I'll hush because I think I'm the only thing standing between you and adjournment for lunch. Dangerous place to be.
It's not a question, but I've had the opportunity to hear Paul Purcell about it.
Right.
He does an excellent.
Paul, that was one of our events that we've just, that'll be a next report because that just occurred. But we've had people in the state conferences that talk about response. He also just gave us a training. It was quite interesting and fun on makeshift medical, which is how to make all the stuff you need and don't have in a disaster out of the stuff that's laying around in the disaster. And it was quite an interesting discussion for all of our veteran members into how to create transport mechanisms or how to create splints out of what's in the debris, how to create ventilators, all kinds of things.
If I may interject, Paul will be doing some additional training coming up. You might see it in our report. He does training for us on personal preparedness, how to prepare ourselves to be deployed so they don't have to worry about our family, actually preparing ourselves and our families. He's going to be recording that and we're going to make it available to other MRCs and our members as they come on.
We could put a link to that on our website if you like to, so.
And we can certainly do that. We have gotten the mechanism now with our video and audio capabilities to record all of our trainings so that people that can't drive into where we have the central part of the training can then go back and get it on the link or can view it real time when we have the telehealth platform. COVID taught us all of that.
Any other questions for Dr. Harvey? Dr. Madero?
Is the majority of your operating funding come from the commission or do you have funding from outside sources as well?
We have sought funding from other sources and we have achieved some limited funding. The federal government, despite MRCs being a federal program, most MRCs continue. They like you to have an MRC, but they don't fund it from the federal standpoint. It's about $40,000 that you get when you start. We have received one, some through actually a resident who achieved a NACHO, which is the National Association of City and County Health Officers grant. And that was utilized to entice young physicians and residents into the MRC. That was a grant that we received a few years ago. There are limited grant funds that are out there available, but most look to this being supported by their state activities in disasters, which often means if left to that, it would be after the fact as opposed to ahead of the fact preparedness. Because if you work with FEMA or GEMA, you have to submit any receipts and then wait for a reimbursement. When I did that with Katrina Rita, it was 3 years before we got any reimbursement funds.
So it's important.
It is very.
It would be
important, and we
detrimental for
appreciate
you.
the commission's support and we cite that, it's been cited in our brochure. So we recognize that and we feel like this is as much a part of the state effort that we have with how to respond to emergencies and disasters. Hopefully we don't have to utilize it all the time. We're there when we need to.
We do recognize the Trump Commission regularly.
Other question?
Any other questions?
Very good. Chip has a report. Has now 5 K9s in the K9 response team that goes with the team whenever we go out. So they've actually been in the trainings. And it was somewhat interesting that they were all absolutely exhausted after going through the training. They actually worked to help with the crowds and calming the people that are injured. And Chip was disappointed that Jack didn't come today. So he's already talked to Fred about that. Jack is Fred's dog. But thank you very much for the continued support. And if there are questions that y'all have about our continued grant support or application or utilization, please get in touch with me.
Okay, thanks, John. We appreciate it.
Thank you very much.
Okay. Move us on to new business. I don't have anything or have not heard of anything, hot items coming in at the last second since the program came out. Is there anything that I missed or needs to be brought up? Okay, we're hearing none. Can I get a motion to adjourn?
I'll make it.
All right, second, okay. Stand adjourned.